So good morning, everybody. We can start taking our seats. So good morning, Commissioner. I'm going to call the Human Services State Agency uh, meeting to agency presenters to order, and you're our first up. And Representative Walker, do you have anything you would like to say?
Good morning.
Commissioner, do you have any few opening statements you'd like to make?
Yes, good morning, Senator Austin, Representative Walker, and distinguished members of the Human Services Subcommittee of Appropriations. My name is Amy Porter, and I'm the Commissioner for the Department of Aging and Disability Services, and I'm happy to be here today to talk about the governor's recommended budget and the great work that our agency does. I am joined by, would you like to introduce yourself?
It went down. There you go.
Good morning, Jasmine Berry, Fiscal Administrative Manager, Aging and Disability Services.
Thank
And we
Thank
know you have quite a day in front of you, so we're happy to answer whatever questions you have for us.
Thank you. So I want to start with transferring the driver training program from ADS to DMV. And this has been in DMV before, is my understanding, and come
Yes.
back because a lot of people did not understand the disability component of it. Have we ironed out what the problem was before, or are we just setting ourselves up for another time when we're going to bring it back again? Because really, DMV is not designed for disability issues. You are. So what's going on there?
Yeah, that's a great question. I do think that we have ironed out the issues. There are just 3 staff in the program. There's a supervisor and then 2 driver training inspectors, and they're incredible. The work they do is great. We did have a waiting list during COVID, as you might imagine, because people with disabilities weren't out learning how to drive at the time, and it was difficult to have the protocols in place. But the program is back up to date, and the reason we're transferring it is sort of, you alluded to it. The Department of Motor Vehicles needs to be and wants to be accessible to everyone, including people with disabilities. So having the need for somebody with a disability to start at DMV, then bump over to our agency and have to come to us for training, even if there's somebody who has a license already, maybe from another state, we want to make sure that DMV has the ability to address the needs of individuals with disabilities. So we're fully committed to supporting DMV during the transition. The staff that are there are great. So them moving to the agency instead of, we're not moving any vacant positions. We're moving 3 very qualified staff. So they bring that disability knowledge, and we're hopeful that they can transition that knowledge to other DMV staff as well.
So we're not setting ourselves up. You're going to make sure that you are committing to making sure that DMV understands the issues for people with disabilities.
Yeah,
That's a
Commissioner.
big responsibility to make sure you have a very small agency and you're transferring people over. And we've done this before and it has not followed through. So I take you at your word that you're going to be looking at this, but you know that the disability issues are near and dear to all of our hearts, and to move it back and forth doesn't do anybody any good if we're not going to make sure that it actually works in favor of those with disabilities.
Yeah, Commissioner Guerrero and I have had a lot of
He's
conversations
great,
about
and
it.
so are your staff.
Right.
I'm not talking about that. It got swallowed up in DMV before, so it did not have the focus directly for those with disabilities. It was not that Commissioner Guerrero was a problem or your staff were a problem. It was that when DMV got this responsibility before, it ended up being swallowed up by the other many important things that DMV does. And you're a smaller agency with a little bit more clear focus on disability rights. So if I have your word that you're going to oversee this, because I'm going to come back to you, not him, and say, what are we doing here?
Yep. And I will bring him along with me and we will answer whatever.
Okay, you
questions
can bring him
have.
along, but I'm going to directly ask you the question.
Understood.
Okay, and then I want to talk about this reduced fall prevention funding. Do you know how much is in fall prevention today? Because this is taking out 191,000 and change. What's in there today?
You can answer.
About $383,000.
Okay, so you got to say who you are again. So,
Jasmine Berry, Fiscal Administrative Manager. Balance is $383,000 for fiscal year 25.
and what does that support?
So the fall prevention program right now supports education and training. We did have a contract with Yale, but the person that ran that contract retired and Yale decided not to continue with that body of work. So we're in the process of developing a request for proposals to really get one, education and awareness, but also some of the evidence-based practices out into the community. So working with senior centers, working with fire departments, working with municipal liaisons to have them have the tools around fall prevention. So we haven't used the funding because we lost the contract and our staff person retired. So both things happened at the same time, which is why we had the funding, additional funding. And now we're going to start to ramp the program up again.
And the dollar amount there is how much again that's left in the fund?
I'm sorry, repeat the question.
What is left in the fund after we remove 191,000? What is left in that fund? Your mic turned off.
About 290,000.
290,000 will be left in the fund. OFA, if you could verify what's left in that fund, please. The reduced workers rehabilitative services funding, we're reducing that by 405,000. That comes out of the workers' compensation fund. What will be left in that?
$565,000.
$516,000, give or take.
Give or take.
Okay. And what does that do?
So the Workers Rehabilitation Program is a voluntary program for individuals who are on workers' compensation and who decide that they want to go through our Workers Rehabilitation Program to maybe receive additional training. They're folks that probably can't go back to the job that they were in. So maybe they want to look at a slightly different job within the same company. Maybe they want to go back for training for a new job. So the Workers Rehabilitation staff work with them to develop an employment plan, whether that includes training or other services, and they'll help those individuals go back to work.
So how many, what is the age range that you're working to help people out?
Yeah, it's working age adults. So any of us, if we have workers'
So it could be
compensation.
somebody 30 years old.
Yes.
So it's not for older people on workers' compensation. Conversely, the fall prevention is what age range?
Fall prevention is for older adults, and the workers' rehabilitation is anybody who's working and has access to workers' compensation.
So, so I'm a little confused. The fall prevention is for older adults. What is the definition of older adults? Because I'm older. I am older. Let's just face the
So
facts.
we have a number of older adult programs, and sometimes the eligibility is 55, sometimes it's 60, sometimes it's 65. So we'll make sure that we have that exact eligibility age for you.
Okay. At either one of those, I am qualified.
Right, right. But
All of the above.
and the fall prevention, because we are working with, we're doing that education and awareness, it can actually benefit anybody. I mean, any of us could be at risk of falling. So it can address the needs of a larger population, but it's particularly designed. It's not a particular service. It's more that education and awareness. And then we have the evidence-based training to be able to work with individuals. So we can get you the specific eligibility requirements for any of those.
Well, to be clear, we have the Department of Aging because we have a huge senior population.
Yes, we do.
And if we're going to cover the whole population, then we don't need the Department of Aging. We're going to call it the Department of People. And so, I want to make sure that we're actually covering seniors because we do very little for seniors in this state. Very little. Representative Walker and I have talked about this over and over again, that seniors need to have specific services and we need to be able to have you interface with senior centers or other groups. And so if we're not doing it for seniors and those with disabilities, like we're moving disabilities out of your agency over to DMV. We have senior services that are anybody, and we have rehabilitative services that are for anybody. And they're coming out of two distinct funds, not out of the general fund. Like, it's very easy for us to move 290,000 out of fall prevention out of the insurance fund into the general fund. It's a small dollar amount. It makes more sense. It used to be in the general fund. And so that's something that we could look at doing, but I'm a little concerned about a number of things in here. So I have to really wrap my head around what we're trying to do relative to things. My sort of last, but not really last concern is looking at some of the other funding sources for independent living, programs for senior citizens, and aging in place. All are concerns of mine relative to the ability to work with them. So, but a few people that have questions. Representative Gilchrist.
Thank you, Madam Chair. Good to see you.
Good to see you as well.
My question has to do with legislation we passed last year that established the Bureau of Deaf, Deafblind, and Hard of Hearing. And correct me if I'm wrong, but I just want to talk through. I believe we used ARPA dollars to establish the director of that bureau. And just wondering, is that position funded in this budget from the governor? When do those ARPA dollars run out? I guess those are the two questions at this point.
Thank you for the questions. We did hire an individual to be the director of our new bureau for services for persons who are deaf, deafblind, and hard of hearing. And that individual started at the end of December. They are funded through ARPA dollars. So with the budget, with the ARPA budget that passed, or the ARPA allocations last session, we were allocated $200,000 to start the bureau, to hire a director for the bureau, to hire an administrative assistant for the bureau, and no additional supports were built into that $200,000. That position is not reflected in this budget. We have the ARPA dollars for it at this point. And your second question was about when they ended. So those dollars are have to be expended by December of 2026.
Thank you. So at this point, we only have funding for 1 year of that director position, and it doesn't cover the admin. It just currently covers the director's pay.
Correct. We have not filled the admin because we didn't have enough funding to do that. The individual who is in the position also, there are interpreter needs.
Okay.
So we need to be able to build those to support that individual to be successful in their job, and to assist the community as well in being able to communicate their needs.
And I know you said it, but and the money is done by December 2025?
2026.
2026. Okay. Thank you. Thank you, Madam Chair.
Can I just take off of that question? You said, I know the money's available till till December 2026. Is there enough to support the funding for that director's position until that time frame? And is there enough to provide them those supports that they need relative to that? So all ARPA dollars we have until 2026, December of 2026, to reflect that. This budget that we're working on right now is FY 26. So it covers all of this year and half of next year?
The budget would probably cover, because the individual was hired at the very end of 2024. So it will likely cover the person through all of 25, calendar year 25, and the majority of calendar year 26.
But it's not in the budget for the rest of of FY 27, which ends, and so we need to Representative Gilchrist is asking the question. That's why I wanted to clarify this. She made the assumption that we were going to be good until 26, but there's nothing in the budget in there reflecting, and you're saying it covers most of 26, but you don't know exactly what month that would end. So it could end in October.
We can calculate out based on the individual's salary. Now that we have a person in that position, we can calculate that out to make sure that we can tell you at the working session exactly when that support will end.
So we need that because we have a position in, and right now we're setting it up for failure by only supporting it for calendar 25, which we're in right now,
Correct.
and sometime in calendar 26, but we don't have a date when that ends. Right?
We can definitely get you that information for the working session.
Okay, because we need to make sure that I think what Representative Gilchrist is trying to figure out for the biennium, what do we need? So that's something that we need to find out. Are you all set, Representative? Senator Lesser?
Thank you, Madam Chair, and thank you, Commissioner Porter, for your testimony. Similarly, one of the challenges we have is that because your agency, as I understand it, majority federally funded, we have trouble seeing the full picture of where your agency is. And in terms of things like elderly nutrition, it's hard to come up with the right number for us if we don't know what's happening elsewhere in the agency. So I know there's been a lot of disruption nationally to grants and funding from the federal government. Where are we? And can you just give us a brief synopsis so we can understand how the state budget could be implicated?
Sure. So you're on point. We are heavily federally funded. We are about 70% federally funded and about 30% state funded. Similar numbers for our positions as well. We at this point have not received any messages from the federal government around stoppage, any grants that have been interrupted. So we are proceeding business as usual with all of our programs.
And where can you give us some specific, I know that there's a lot of interest in this building into the elderly nutrition program. Where is that funding level versus the last couple of years?
So there was a cut at the federal level. There are a couple of different funding sources at the federal level. So where one piece increased, another piece decreased, and it was a net decrease in the federal funding. Do you have those dollars that you'd like to speak to specifics? I don't have the specific. Here at a glance will show how much federal and how much state.
Okay.
Hold on one second. We can provide at least the breakout of federal versus state dollars at this point in time.
Okay. Okay, so our state BOA federal funds were at about 21,745,000 for federal funding. Of that breakout, our NSIP dollars are 916,000. And then some of the nutrition services block grant is $182,000. And then our Title III congregate meals is about 5.4 million. Home delivered meals is about 44.5 million for our federal nutrition funding.
And that represents a cut from the previous years, you're saying?
It is, yeah, it is a in total, it was a net decrease, not a substantial one, but it was a net decrease. And it happened around the same time that the ARPA dollars were ending. So the legislature, the governor's office, everybody worked together to ensure that the elderly nutrition dollars were, that there was a heavy investment in elderly nutrition from ARPA dollars. But we made it clear the whole time that that was going to be, a one-time investment, and that during COVID and during the recovery, that if they needed, our levers are sort of how many days a week we can provide meals, how many meals a day we can provide. So those were ramped up during COVID and the recovery. And then with ARPA dollars going, they had to ramp back down again. And then at the same time, we had this federal cut. And we can get you a breakout of exactly what those dollars look like.
That would be helpful. And I know that we have not experienced a net decrease in the price of eggs. So there's been a lot of pressure on the programs in this region, but across the state. And Senator Austin's seen that a couple of years ago in her district, and it's been impacting all of us. Last question, if I might. There were a lot of senior centers around the state did receive funding through ARPA program. I know that funding was restricted. So going forward, informing our decisions here, can you give us a list of the agencies that applied but have not received funding because that funding was not available? Could you get us an up-to-date list of that?
We can definitely get you the list, and just so you have the numbers, we were able to fund 118 beneficiaries. There were 48 entities who submitted but didn't receive funding. And then we had just 15 towns that didn't submit anything by the deadline, and we can get you the breakout of those towns.
I would appreciate that. Thank you very much. And thank you, Madam Chair.
Representative Dathan.
Thank you very much, Madam Chair, and thank you for your presentation this morning. It's good to see everybody. Two things. With the vocational rehabilitation for the disabled, I know we've had a slight increase in our appropriation from 24 to 25. Would you be able to bring to the working group some details about who is eligible for those services, and how we are expanding those, and how we're working with OHS to make sure that folks in our disabled community are able to get vocational services or work services? The second question I had, I know that you had a decrease from what you had asked for the governor for fall prevention. As somebody of a sandwich generation, my mother fell, and it ended up costing a lot of money in terms of 2 surgeries for a broken femur. And I'm just wondering, do you all have any sort of data that, we're kind of monitoring how we're helping our seniors with this sort of services so that we can prevent falls? Because not only does a fall cost money for, Medicaid or Medicare, but it also really can put seniors out and put them in the longer term, not being able to age in place. So if you can share either if you have some information today or bring to the working group, I'd greatly appreciate it.
Yeah, I'm sorry to hear
Thank
about
you.
your mom's fall. And definitely we're very interested in fall prevention. We talked a little bit about that at the very beginning today, that we do spend a lot of time on education and awareness and working with communities, municipal agents, senior centers, fire departments. And we're really excited because we have a new person who's focused on that on our staff. Our Bureau of Aging, a good portion of our staff retired in the big retirement, and we have new staff. They're so energetic and so excited to work on initiatives. And the person who's working on the Falls Prevention Initiative is partnering regularly with the Department of Public Health, and they've started a Falls Prevention Coalition to be able to really get the word out. And then also we're working on a request for proposal to then add some of those evidence-based practices in, so that senior centers can be offering particular, better balance activities and things like that, and other places in the community. So we can get you the detail on what that's going to look like and what the Falls Prevention Coalition looks like.
Yeah, that'll be helpful. And just to understand, if you do think you're going to spend that $383,025 as part of your work, that would be great.
Yeah, for sure. Thank you.
Thank you. Thank you, Madam Chair.
Representative Nolan.
Thank you, Madam Chair. Good morning. I'm just curious, and I don't know if I missed it or not, when you talked about the meals for the seniors, how much does that mean that they're losing? And when it comes to meals per day, I mean, is there an estimate of that?
So it's hard to estimate based on meals per day because the way that our elderly nutrition funding works, based on federal law, is we get the money from the federal government. That money goes by formula, by state statute, out to 5 area agencies on aging. And then the area agencies on aging, or the AAAs, we call them, do a request for proposal. So it's a competitive procurement for elderly nutrition providers. And based on the area that they provide, based on the number of individuals in that area, because it's not an entitlement program, they do their best to stretch the dollars and meet as many needs as they can. But sometimes that means they're only able to offer meals 3 days a week. Sometimes it's once a week, sometimes it's 5 days. So it depends on really the service area and the needs of individuals and the budget for that particular area. We can do our best to get you what that detail looks like for the working group.
Yes, please.
Okay.
And a second question, if I can. I was looking in here and it talks about eliminating funding. Then I seen that it said for Stanford Senior Center. But I'd be curious, do you have something that you can send us or have for the working party that shows how much funding goes to each senior center?
We can give you the breakout of the ARPA dollars that went to the senior centers, which senior centers were able to take advantage of that opportunity and which senior centers weren't able to, and those that did not put in an application, we can get you that. The support for the senior centers is part of the support that the area agencies on aging provide within their communities. So we can get you as much detail as we can on the senior centers. They are vital partners in our aging network for sure.
Yeah, I'd just like to see what throughout the state of Connecticut, how much funding goes to senior
None.
centers.
None.
No.
Representative Nolan,
No.
none. Absolutely none. Zero.
we did the.
That's why we did the ARPA money, because
Okay.
absolutely none goes to senior centers. Let's be really frank about it.
Okay.
Area agencies on aging get some money, but senior centers broadly get $0 from the state. Zero.
So how
How do they?
how Stanford?
Stanford was called out last year as an individual allocation for 1 year. And then that was, my understanding, it was mistakenly left in and then taken out in another reiteration of our OFA sheets. Like anything else, sometimes there's a dollar amount that gets added in for one group for 1 year. And that's what happened with Stanford. But every other senior center in the state had an ability to apply, because I put Representative Walker and I put $10 million in to go out to all senior centers. During last year's ARPA funding, the remaining dollars that people had applied for after a certain time frame were taken away to give to UConn and the state universities and other ARPA things. So it's true. That's the way it is. But we took the money away from the rest of them. For 48 of them did not get the funding that they applied for. 15 didn't apply for any funding out of that availability.
So you're saying that funding might have went to UConn versus?
No, that went to the other dollars. We had ARPA dollars that were given to other places. So they looked at ARPA that was not spent. This was not spent because they had, when they originally were getting the money, they had until June 30th to apply. They didn't apply till June 30th, but we cut it off earlier than that. Not
Okay.
we, but it was cut off earlier than that. So 48 towns did not get the funding.
So we need to insert some money for senior centers.
Well, that's a thought.
That's a thought. I don't know that we're inserting any money for anybody until we actually get a chance to talk about it, because there's a lot of requests for funding.
Okay, I'll come back for other questions. Thank you.
Representative Walker.
Thank you. Thank you, Madam Chair. First of all, it didn't go to the colleges. It was reappropriated to other needs in the budget. So let's not put
Okay.
elderly against higher education. That is a wrong thing to do. But I also want to say that that the fastest growing population in the state are people
Seniors.
over 65. And they're coming here because of the fact that they know that there is a group of people that are focused on making sure that they get their services. We want to retain them. And so therefore we do have to go at it and make sure that the services that they need are being met in those facilities that we have now passed them off to. We cannot forget them. So I agree with you, Representative Nolan. This is very, very important. So, but I just want to remind everybody again that they vote and they come out and they express themselves. So it is important that we take care of them. Not only that, but they also were here before us. So thank you. I didn't have a question. I just want to make a statement. Thank you.
She and I are both in that older generation.
I'm older than her.
I don't even know if that's true.
10 years,
How old are you?
73.
I'm gonna be 70 this year. You're only 3 years older than me. I don't know what you're saying.
I'm still older.
Goodness gracious. All right, does anybody else have any comments or questions? Yes, Representative.
Thank you, Madam Chair. Thank you, Commissioner. This is a relatively small one. Under policy revisions, I see about a reduction of about $900,000 or so. And it looks like there are a couple of positions involved with that. What are the other reductions?
So the changes in our positions were the 3 positions that are recommended for transfer to the Department of Motor Vehicles for our driver training program.
Yep.
And then -1, because we got a position added into our agency, somebody who was already supporting our agency and through the central contracting unit at Demas. When that central contracting unit dissolved, that individual came to us. They were already working on our contracts, but we are thrilled to have them as part of our agency staff. So that's the difference. There were -3 + 1, so that's a net of 2.
So again, it's all personnel, then salaries.
Let me see if I can make sure I'm looking at the same thing that you are. You're on the, looking at the
Totals.
OFA?
Totals. That's the easiest way.
Policy revisions. Okay, so there are also a couple of other things in there. There are the 2 reductions that we talked about already, workers' rehabilitation and the fall prevention. But there were also the elimination of funding that they were meant to be one-time investments. So, but they carried over in our budget. So they're just removed from our budget. They were intended all along. The Aging in Place pilot and the Stanford Senior Center were meant to be one-time investments and not for these 2 years. So that's the balance of the policy revisions.
Okay. All right. Thank you.
Well, Commissioner, I think you got off rather easy today, so seeing no other questions, you're all set.
Thank you.
Up next is the Department of Social Services. Is the Commissioner here? Good morning, Commissioner.
Good morning, Senator.
How are you?
I'm fine. I just need a moment to get my glasses and I'll be ready to
Take your
go.
time.
Okay, thank you.
I can't not wear my glasses because I couldn't even see the microphone if I didn't wear
Yeah,
my glasses.
I am at the same place, so I appreciate that. Thank you.
So
Let me know when
Representative
you're all
Walker,
set.
Senator Austin, thank you very much. And ranking members, Senator Summers and Representative Nuccio, and esteemed members of the Appropriations Committee. I am Andrea Barton Reeves, Commissioner of the Department of Social Services. We appreciate the opportunity to be before you today to answer questions about the department's fiscal year 26 and 27 budget as proposed by Governor Ned Lamont. I'm here today with many members of our agency leadership team to provide you with any further information about our programs and services. We support the governor's budget. We believe the budget and its recommendations enhances our mission and provides us the resources necessary to support those that rely on the agency. And we look forward to working with the legislature as you review and deliberate the governor's proposed budget. And with that, today I have with me please go ahead and introduce yourself, Brianna.
I'm Brianna Mitchell. I'm the new CFO at Department of Social Services.
Anything else, Commissioner?
No, I don't have anything else. So we are ready to take
Okay.
questions.
So I have a couple questions to start us off. The hospital supplemental payments that are to include $140 million for you. Have you had a chance to review the hospital supplemental payments change that we have?
The one that's proposed in the governor's budget,
Yes.
I have. Yes, I have had a chance to review
And
that.
have you seen the latest number of articles where the current administration does not like the hospital provider tax system at all? And is saying that they believe that that will not make it through. If that did not make it through, what would be the end result on your budget?
I just want to make sure I understand the question. I am not familiar with those articles. What I've seen,
Oh,
I'm sorry, please.
I'm sorry, they're in the New York Times, the Wall Street Journal.
Okay.
They're in probably 10 more national kinds of
Yeah,
newspapers where the administration has, the current federal administration has indicated that the hospital provider tax system is essentially a Ponzi scheme, and they're not interested in doing that any longer.
I'm sorry. I completely misunderstood you. I thought you meant the state administration.
No, I do
have
not. They are very much in
Okay,
support of
I
this.
was so confused for a
I'm
moment.
sorry, I
No,
apologize
I've
then.
read the articles from the federal administration. I'm very familiar with their position.
Those are the ones that I'm
Yes.
talking about.
All right,
Not the,
thank you.
not our administration, but
Ah, okay.
you deal with the federal government,
Would-
your department. I
Yes.
agree, every department has its interchange with the federal government. Your department
Yes,
brings the most revenue into the state
yes,
through the federal administration. And
Yes.
this $140 million is a piece, but it's not the only part that you bring in. You bring in more, you bring in billions of dollars
do,
into the state
indeed.
through the federal government.
yes.
If we lost this $140 million, what would be the impact to your agency?
It's the impact to our agency would be significant, and it really would mean that we would have to in some way adjust the supplemental payments that we give to hospitals and find that $40 million, that $140 million within state services. But that is true for every bit of federal matching money that we get. We would somehow either have to readjust the amounts of money that we give, and I would imagine in some circumstances, we would have to eliminate what we're giving because as a state, and I don't know any state that has the resources to be able to replace every federal dollar that might be lost as a result of changes. So this, in fact, I think what you're alluding to, Senator, is it is certainly contingent upon the position that the federal government will take. At the moment, as we sit here, our FMAP, right, our federal match numbers remain the same. And other than a bold statement about the federal government's permission as a position with respect to how it feels about the match in federal dollars, particularly with the hospital tax, there hasn't been any action that's been taken. So at this point, we don't really have any basis upon which to make any specific changes to what it might look like, other than to say that if we couldn't get the federal match, that it will mean making some difficult decisions.
In the Medicaid, thank you for that. And I'm really, I don't want to make any mistake in what I'm saying. I'm not alluding. I'm actually saying that I believe that there's going to be a significant change in the amount of Medicaid that we get.
Yes.
And I think it's going to dramatically impact your ability to provide services to people. And I know that we cannot provide all of those services through state dollars.
Correct.
So I don't want to say I'm alluding to anything. I am speaking what I perceive to be the fact on what is happening at the federal level and its current potential impact on services that we provide to residents in the state of Connecticut. The the increase on Medicaid provider rates, do you have a list of who will be getting the increase on provider rates by job classification?
No, we do not. We do not. So the primary focus will be on primary care. So we will do, I believe you're referring to the Medicaid landscape analysis and the rate study. Is that correct?
Well, it says in the budget, increase Medicaid provider rates, provide
Yes.
funding of 10.4 million in year
That's
one
right.
and 25 million in year two.
That's right.
Because I would really like to know what job classifications are going to get this before we actually have a budget that comes out. So can you
Understood.
provide us those job classifications?
Yes.
Because I think we can't just sit here and guess that it's going to be our favorite provider rates that are
That's right.
increased. We need to know exactly who is getting an increase.
Okay.
So if you could bring that to the working group.
We can. So what we're doing, Senator, is we are working through the specific provider codes in very much the same way we did with the same dollars that we had available to us during last year. When we made the adjustment to behavioral health. When we increased those rates, we actually went to a very granular level and looked at the codes that needed to be increased in order to create better access to care. And we're doing the same thing here. There are many, many more codes than there were in the behavioral health space. So it is taking us a bit longer. And I will have as many ready as I possibly can during the working group
And what those rates will be.
and what the rates will be.
So
Yes.
that we can actually see.
Yes,
So much of the $10 million will go here, 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 and here.
that's
And
correct.
this 10 million is actually 20 million, or is this 5?
It's actually 20 at the current FMAP rate that the federal government is providing. Again, the caveat you provided earlier also applies here.
Yep. But this is state dollars. This is
That's
not
right.
reflective of federal dollars
No, they
here.
are not.
And I have a lot of questions, but I'm going to go to one more and then go to other people.
Great question.
Reducing the ambulance rates to the FY 24
Yes.
level. The FY 24 level, we increased the rates for ambulances because they were not being able to provide the services out in the community. And now we're decreasing those rates. Did something change that made it more cost effective for them out in the communities? I'm a little confused by that. Why would we do that? Is this just a money savings mechanism, or do you have data that supports us decreasing the rates for those people?
I don't have any specific data, Senator. I don't. I do know that in comparison to other providers whose rates we have increased, that the ambulances have seen more steady increases over time than other providers we've provided rate increases for. So it was within that context that the determination was made to make this particular change. And that is the basis for that particular decision.
Well, I know they weren't going to make it. That's why we increased the rates.
I understand.
So if I have, ambulance services around the state are being bought up by Yale and Hartford Healthcare because those ambulance services cannot remain independent any longer. And I'll say specifically for rural communities, rural communities cost more to run because they travel more miles. And most rural communities don't have hospitals embedded in them. So it takes them longer to get to a hospital than it does for someone that's in, say, the city of Norwich.
Right.
And so they actually have to travel into Norwich if you're from the outskirts to get to the hospital. So it costs them more in transporting an individual than it does on a per mile basis. So I'm a little concerned I'm a lot concerned on that issue. So, but Representative Walker.
Thank you, Madam Chair. And good morning.
Good morning.
Good morning. Yes.
Good morning. Good morning.
I where do I begin? First, I want to start with your overtime. Your overtime in 22 was 2.2 million. In 24, it was up to 4.4 million. And then in 25, it's 2.9 million.
Yes.
What happened?
Yes. Well, what happened is that we had to rein in our overtime spending. And so we had a significant amount of overtime that we were using. We looked at that in the context of how overtime was being spent, not just in our agency, but across the
No.
board. So we created different criteria under which overtime could be used. It is used primarily in our eligibility operations. So where our call center and where people make determinations around eligibility, that's where most of it is used. We have different approaches to using our overtime now. So it's specific to days and hours. It's also specific to certain types of tasks. There are high priority tasks or lower priority tasks. So part of it is efficiencies that we built into the ways that we use overtime, and also understanding that the bulk of it was being used in one part of our agency, but there was a significant need for more overtime in other parts of the agency. So trying to lower the amount that we spent altogether, and then using it more equitably across the agency is how we came to this particular change. So we are trying to stay under the $3 million level for our overtime, and that's what it is. That's the manner in which we were able to accomplish that.
So that it's not, you're not reducing access hours for the public or anything like that?
No, we are not.
We're still keeping the same hours in the sites that are out in the community?
Yes, the hours are the same at the resource centers. They
Okay,
are.
so then I look over and see community services is down by 36%. It went from 7.9 down to 4 million. How did you achieve that?
Let me see, community services. I'm trying to determine because we use so many different terminology. I'm
okay.
not sure what
It-
specifically we're referring
It's
to.
it's from OPM, but community services, and it just shows the 36%. So if you could just get that, I'd
I
really like
will,
to know,
yeah,
how did
because
we
I'm-
achieve that
right.
reduction? I'm very concerned when I see reductions, because
Okay,
reductions usually mean reduced services. And what I'm trying to make sure is that our community services, which are really critical, you know this.
I
I'm not
do.
preaching to the choir. So I
Exactly.
mean, it just, I would just like to hear about that.
Okay.
Now, I'll ask one more and then I'll stop. The one that I dislike the most, and I need to understand, is the centralization information technology function at under DAS.
Yes.
Senator Austin and I have fought vehemently against having you go under that umbrella, you and Department of Children and Families, Department of Transportation, and Department of Motor Vehicles, because of the very large infrastructure that you guys have to manage in order to provide the services and operations. And I have yet to hear why it needs to happen. I understand DAS is doing a fantastic job of doing the 30,000 foot, all that, but you guys are so much more than 30,000. And so are the other three agencies that we have refused to do this process. We would like to know what services you have now. I don't want, and what services you are going to have. And the concern that I also have is the transfer of the positions.
Yeah.
So I'd like to get a little bit more detail, and I'm not, I don't want to, I just want logic. I don't want anything else like that. Pure logic, please. Okay.
Would you prefer that in the working group, or would you like me to address that now?
You want to address it now?
I can address part of it now and then the
Oh.
rest in the working group,
Okay.
certainly. So, actually, we find that there is some benefit to having these services consolidated,
Okay.
because it allows us to leverage enterprise-wide savings in some respects, enterprise-wide licenses as an example, and solutions that we couldn't do ourselves if we were isolated. So an example of that is we recently were working on a project where we were going, and we need to upgrade our child support system.
Mm-hmm.
And so the ability to do that research, there are only a few vendors. This is very true for a lot of the services in the social services space. There might be one, two, you're lucky if there are three vendors. You know, an example of that are the cards that we use for EBT, for SNAP. There are only two vendors in the entire country that do that. You don't have a lot of choice around that. But in order to be able to find out what is happening in other states and maybe how other agencies have implemented systems, we don't really have the capacity to do all of that research. So DAS does that for us and then brings back recommendations for those purposes. With respect to the day-to-day, our laptops, our desktops, you know, sort of our day-to-day needs of support, they're very responsive in that regard. So we do find that there's a lot of value there. Where we have challenges in finding value, we bring that directly to BITS, to Mark Raymond and to his senior leadership team. And we will say, you know, it would be good if we had more conversations, let's say example, for Salesforce licenses, because the state is moving towards Salesforce as a particular platform, an IT platform. We use Salesforce for a lot of different things and want to use it for different things, but getting those licenses just for us can be a very expensive proposition. What we ask for at times is for DES to tell us where else are Salesforce licenses being used, and can we leverage the volume of the state rather than just us as an agency to get more of those licenses. Those are things that we don't necessarily have the ability to do on our own. We also have an internal, to your point, an internal business systems unit. And I think really the challenge, or maybe even some friction or conflict, it might arise there because there are people who worked in that particular department for 2 decades, right? They've seen every iteration of every system that you might imagine. So we have to really work more collaboratively with BITS when they're lending their overall enterprise-wide subject matter expertise and trying to blend it with what we know as our agency-specific expertise. That, I think, is probably the area where we need to continue to do some growth and some work. But with those positions moving over, that some of that goes with them, and that is something that we have to work through as well. Yeah.
I want to say that was the first time I actually heard the positive to having this transfer. And I thank you for that. DAS thanks you for that because they've been talking to Kathy and I for a long time. But it's the core part that you talk about that is the most frightening for me. Because again, what you described is great, but that's 30,000 people.
Right.
It's down here where you have your case management, your processing, your Medicaid, all those things that are so important that your agency have total control over and access to on a regular basis that has to be maintained. So somehow, maybe the 65 people needs to be cut down to 30, and you keep 35 and they take 30 and they can do their broad brush. But your core operation has to stay with you. So you can give us the data that is necessary for us to understand and ask these questions. And I'll probably bring the same thing up with Department of Children and Families. It's important that their case management, your case management is internal. It should never be made available externally because of privacy, et cetera, et cetera, et cetera. So we can talk about that and DAS and OPM, if you're listening, Judy, we'll be willing to talk, but I got to make sure that we don't lose access to the data that we need to hear and see in order to see the operation. So thank you. Thank you, Madam Chair.
Representative Nuccio.
Thank you, Madam Chair. Good morning. How are you?
Doing well, thank you.
Good. I have a few questions I was hoping you could help with. And as Senator Austin said, you guys are a big organization and you're a lot of pages, so I'm sure there's a lot of questions, but I'm going to try to keep it to a few so somebody else can ask and then we can circle back. I'm just kind of going to go in through order through mine with no relevance, but the increased birth to 3 rates here, is this going to open more seats or is there a backlog on this? What is this 4.5 million specifically going to do? Because I know you guys have been talking about this tiered system. So how does this kind of play into that?
So I actually will defer to OEC to answer the specifics about how the money will be used. We essentially are the funder for that process, and it is designed to open more opportunity and to provide more resources. And it's also designed, as you know, there are so many children and so few childcare slots and so few places where children can actually get access to quality care and their families. So the Office of Early Childhood, funded primarily through a number of resources, including DSS, will then be able to have the benefit of these additional dollars to put to the agency. But my understanding is that it is mostly for childcare.
Okay, so it is going to open more seats, but it's also going to increase rates, is what you're saying.
That's right.
Okay, all right.
That's my understanding. And I'm sure that Commissioner Bai will correct me this evening when she watches this, but that is my understanding. Yes.
Okay, in relation to, I wanted to understand the Med Connect income asset limitation. And I know there's been a lot of talk between the 75,000 and the 85,000, and that the Connecticut median income is 75,000. So we're going even higher than that.
That's right.
Can you give a little bit of background about what exactly this is doing here with the income limit?
Yeah, so what it's doing is it's holding the income limit steady. It was designed to continue to increase through 2029. So what will happen is that the savings that will be achieved by not having the asset and income limit continue to grow would mean that it would hold the limit steady and the number of people participating steady. And that's where the savings would be achieved.
Okay, so the 85,000 is higher than the state of Connecticut average median income, right? So we're still
right.
higher than the average median income. We're putting people on, Medicaid with that. Like even though they're higher, right? We're pausing it at 85, which is higher than the median, correct?
That's correct.
Okay. And then I noticed you have $1 million in here to support development of the 1115 waivers.
Waiver, yes.
So is this just like what is the $1 million going to be used for?
Yes. So what it will be used for is to develop an 1115 waiver to create more community support. That helps to support the social determinants of health. There are many states, we're just a handful that have not actually pursued such a waiver, where these dollars can be used to do things like address food deserts and create more opportunity for community-based organizations to provide more support, particularly for the social determinants of health, which include education, housing, food, and other wraparound supports for families. The difference between this waiver and others that we've done before is this will also include it would include hospitals at the table along with community-based organizations, which is really nothing that has specifically been done under a waiver in this state. Other states have done it. There have been a few. I can get that list of those states for you that have done it. They do have sort of a different structure because we're one of the few states that are not under managed care, so it looks a little different there. But there are other states where I'll use Oregon and Washington State as an example. Those are the two that come to mind. So Oregon and Washington State in particular, Washington State has one of these 1115 waivers. And what they did with that waiver is that they partnered with their largest hospital and they built more affordable housing in their state as a result of that. We've not ever availed ourselves of that kind of waiver to be able to do that kind of work. And obviously having stable housing is a really important part of a social determinant of health. So we wanted an opportunity to use these dollars to write the waiver, to submit it to the federal government to see if we can access more federal dollars. We know things are somewhat uncertain, but it did make sense to us to not do it. As a department, I know we've been considering this for years, and we definitely considered it when I came 2 years ago, and we'd really like to pursue it more seriously now.
So the $1 million is that consulting to help?
Some of
develop
it
more
is
data?
consulting. Yes, it is. Yes,
Okay.
these waivers are quite complex. We've
Okay.
not spent that much on writing a waiver before, but we don't know how large this is going to be. So
So it's kind of a placeholder.
yes, it
Yeah,
is.
no, okay.
Yes.
And then in regard to the Medicaid landscape analysis recommendation,
Yes.
I noticed it's talking about care coordination services for individuals with acute and chronic disease and behavioral health conditions.
Okay.
This is for the dual eligible, right?
Yeah, they
So,
would be included.
okay, so I guess I didn't get to that part. Is this rate increase then for those specific?
Yes. Yes,
Okay.
I'm gonna want to make sure I understand your question. So you're asking about the Medicaid landscape analysis.
Yeah, because like I know what the
Yes.
Medicaid landscape analysis was. That's like where we got all of the information and everything. So
Yes.
I'm wondering why we're doing 1 million and then 2 million. Because it says to support care coordination services for individuals with, acute and chronic disease, et cetera.
It's not. No, okay.
No.
forgive me, I'm getting some, some counseling behind me so I can make sure that I provide the correct answer, because some of the money that's been set aside is for rates and some of it is for other purposes. No, this is for us to establish services for people in long-term services and supports. That's what these dollars are for. Is that- Bill?
For long-term.
Bill, why don't you come up and explain it? Because clearly
I
I failed in this part of the tutelage, so, okay.
Good morning.
Okay, Director. So the next phase of the Medicaid landscape analysis that asked us to really dig in on chronic disease care management outcomes, especially for those that have a disability and older adults. So this brings us to the ability to allow potentially we're exploring like an ASO-like entity to develop a care coordination program for chronic disease care management and to do further analysis on the recommendations.
ASO stands for what, Bill?
Excuse me, Administrative Service Organization.
Say it again.
Administrative Services Organization.
Thank you.
Excuse me.
Okay, so this is for basically like a care coordination program, because listen,
is
I
correct.
think that's part of our problem. We don't know why 290 million over in Medicaid, but if we'd had a better care coordination, we might be able to kind of bring that down.
Part of it, yes.
Yeah,
Yes.
right. I think, that's kind of inherent in the Medicaid system.
Right.
So care coordination, I think, is key. My only concern here, and this is gonna kind of bring in some like just personal experience with this and that. I have older relatives, had 2 aunts, an uncle, and my mother. They all live in like the same, it's a duplex. They all live there. It's a crazy house when you go there. Can't spend a lot of time there and leave sane. But
Understood.
they all have PCAs, care coordinators, right? So at
Right.
any given moment, when my uncle was alive, there's 4 people in there. A lot of people they're just kind of sitting around talking to people, and that is there a way we could care coordinate within homes? Like they don't need 4 PCAs sitting there all day with them. Like if they had one for each house, there's only so many clothes to do and so much food to cook, right? So
That's right.
can we look at something like that, like care coordination within established like addresses and stuff like that? Like it just, to me, it seems like a lot of money.
Yes, we can. And that is precisely what these dollars would go for, is to be able to have a closer look at that, at exactly what you described. And we've heard anecdotally those kinds of stories before where care coordination could be better. And we're glad that the Medicaid landscape analysis actually raised that up, because it helped us to really solidify, I think, what we understood anecdotally, that this could be better. So yes, that could definitely be addressed under this.
Okay, because like I had to like call and help because again, my 2 aunts that live in one place, like one of them has has Alzheimer's.
Right.
Right. So we really need somebody there from 7 to 7. But if we
Yes.
stagger the aides, then we can get that coverage. But it was a heck of a lot of work to try to even get that done.
Understood.
So this, I think, this is a good spend. I have several other questions, like Kathy said. So yes, I'm gonna stop now and somebody else can ask a few.
Representative Gilchrist.
Thank you, Madam Chair. Good to see you, Commissioner,
Good morning.
and your whole team from DSS. So my first question has to do with the elimination of statutory inflation. And this might seem odd because I know that I've been told this is something that is typically put in year after year in the governor's budget proposal. But why I'm disappointed is, we've spent money and time on the rate study and also the landscape analysis. And to me, the large thing they've illustrated is that because we don't continue to update the rates year after year, we got ourselves in the position we're in. And so if I'm reading this correctly, the elimination of the statutory inflation would keep the nursing homes, who we've also done so much work on, and nothing's ever 100% great, but I'm hearing from folks that the acuity system's going fairly well. My fear is that if we continue to stay in this pattern of each year we eliminate those statutory rate increases, we're going to be in the same position we're in right now when it comes to rates. So what is the current nursing home rate? What year is it based on?
Mhm. So I'm going to bring up our
Okay.
nursing home expert, Nicole Godburn. So
Thank
I
you.
do not misspeak. So she
Okay.
is here. That is why half of
Yes,
DSS is
thank
here
you.
today.
You have a great team.
Good, actually technically afternoon. I'm Nicole Godwin, Fiscal Manager for DSS Reimbursement and Certificate of Need. So currently, nursing home rates are based off of the 2019 cost year.
And so if we did the statutory inflation, would that bring them up? What year would that bring them up to?
It wouldn't, so inflation is different from a rebasing. So a rebasing would be a full, think of it as a full wiping out of the rate as it exists and then shifting it to a different cost year. Inflation increases simply bump the rate up according to whatever the price of inflation was for that particular year. So your question is asking about a full-blown rebasing, which would be dismantling the rate, and then we would build it back up based off the cost year, whereas inflation would just be applying the inflationary index for that particular year to the rate as it exists.
And is there a plan to rebase?
No, not currently. Statute requires us to rebase every 2 to 4 years, but currently we're not close to the 4-year period. That wouldn't be until 2027. So there's currently no plan to rebase.
Okay, thank you. I'm a little concerned that we're not doing the inflation then, to keep them up. Okay, my next question, thank you very much, goes to the domestic violence assistance. Could you speak to what the 4 million currently goes for with the state administered general assistance, and do we get any kind of federal match through the saga?
No. All right. So let me answer the last part of your question first. We don't. We are spending all state dollars.
Okay.
So the way that had occurred, what had occurred and unfolded is this. It was originally budgeted or estimated at about the $2 million mark, maybe a little bit less than that. What we found in administering the program is that the cost has just ballooned exponentially to close to $4 million. What we're also finding is that DSS was selected as the agency to administer the program, but we are not experts in domestic violence. We know that at least in some of the cases, very few, this is not the rule, it's certainly the exception, that there are individuals who might not necessarily always be current victims of domestic violence, and that is what the fund was intended for, in part. And we also, we know anecdotally with a few cases that there are some individuals who have been encouraged to apply for the fund, even though they're already still in a circumstance where they may be a victim of domestic violence. We're not equipped to address or assess a person's need with respect to those dollars. So we were strongly encouraging, and fortunately, CCADV, right, the Connecticut Coalition Against Domestic Violence, has agreed to take over the administration of the fund so that the dollars can go directly within the budgetary constraints that were originally set for the program to victims of domestic violence who come to them so that that money can be used more effectively and efficiently. So that's why we've asked for the fund to be moved.
Okay, thank you.
You're welcome.
For the work group, could you bring just a breakdown of how many people were served in the last 2 years or since the program started?
Sure.
What that amount of money looks like, just so we can get a sense of what this looks like and what's shifting over.
Sure.
And then I'll ask one more, even though I have some more too. Thank you. To the various programs that are being reduced. I had asked when the OPM secretary came in to have a list, so just going to follow up for the work group. If you could provide a list of the programs that are being proposed to be reduced and or if any are being potentially eliminated. In the write-up we have, I mean, there's 2 already. At the same time, the legislature tonight will be voting to add money to refugee services since they have been cut already federally.
Yeah.
It seems shocking, quite frankly, to me that we would cut them in our state budget. And then other things like ROCA, services that are very impactful in the community. So just to get a sense of what that looks like.
We can
Is
bring that
there
back.
any reason beyond the need on your end to cut funding, that these programs were recommended for reduction? And if so, I suppose bringing that too, like if there's any
Yes, we can bring
programmatic
those as well.
reasons. Okay,
Yes.
thank you. Thank you very much.
Up next is Senator Lesser.
Thank you, Madam Chair. Thank you, Commissioner.
Morning,
Good to see you.
Senator.
Just with regard, first, with regard to the administration's proposal to effectively repeal Public Act 2394, that's the requirement that Medicaid pay for treatment for severe obesity. I will just start by just expressing frustration. I know a lot of members of this committee put a lot of work into passing that legislation, and to this date, the department has not fully complied with the law. I see in your proposal savings associated with restricting access to those medications, but then a carve out saying, but we do intend to comply with federal law, which requires coverage of Wegovy for cardiovascular risk. Does the department also plan to comply with federal law, and specifically with regard to coverage of sleep apnea treatment for DSS approved medications? I think Zepbound has been approved for that purpose.
For the sleep apnea, yes, our plan is to comply with that. But we do
And-
have to file a SPA, right, a state plan amendment to be able to do that. And with respect to the other weight loss drugs, I think this morning also provided a required notice to provide oral medications for weight loss. So we're continuing down that path.
I'm sorry, can you just elaborate? What did you do this morning?
Yes, I think, did we file that or the notice? I apologize. Go ahead, Bill. Friday. Why don't you go ahead, Bill, and explain what we.
Hi again, Bill Halsey. On Friday, we submitted a Connecticut Law Journal posting, which I think will be published this week, with our intent to submit a state plan amendment to CMS to cover 2 oral medications specifically approved by the FDA for weight loss. The names? Sorry. Tag in.
Hi, Dr. Jody Terranova, the medical director for Medicaid. The 2 oral medications for weight loss are Orlistat and Phentermine.
I'm sorry, could you say that again?
Orlistat
Orlistat
and Phentermine.
and phentermine.
Yep, they're generic drugs that have been around for a while and are
Phentermine has been around for quite some time.
Yep.
But Orlistat,
Orlistat's also been around for a while.
okay.
And those are not GLP.
They're
ones?
not GLP-1s.
Okay.
Correct. They're oral medications that have been FDA approved for weight loss for a number of years.
Okay. So I guess I have some skepticism. I see this healthy number for savings in 26 of $28.8 million. That's a lot of savings, and less savings in 27. But given the pace at which FDA has been approving, I don't know what the new FDA is going to do, but the FDA has been approving GLP-1s for services other than weight loss. I have a healthy amount of skepticism that you're going to be able to achieve those targets. So it would be interesting to see if you could back up that documentation. And then obviously, I think the members of the committee and the legislature have an interest in making sure that we provide that service one way or the other. So if you could help with that, that would be helpful. Next question, Opportunity Center pilot project. I see a request. It's at the same time that you're proposing to get rid of your IT staff. I see a proposal to add an IT analyst to DSS's staff. And I'm just trying to figure out how, if we were to, I know that there are a lot of staffing needs in DSS, and there have hit historically, but if we have 10 staff to give you, how did you arrive at this as being the key priority?
Specifically for the opportunity centers? Yes, thank you for the question. So as you know, the opportunity centers are a priority of the governor. And it started when he came at my invitation, he came to visit what we call our resource centers. There are 12 of them across the state, because I very much wanted him to see how services are delivered to our Medicaid population. One of the questions that came up during one of his visits is why can you only receive Medicaid and SNAP when you're at our offices, when people obviously have an array of needs? It so happened that in the beginning of our tenure as a senior team, we also had the same question. So we were able to fulfill the governor's wish that we open an opportunity center. And there is one that is open in a pilot basis in our Greater Hartford office, which is located in Windsor. So through an appointment process, and you can do that either in person or online, we align with lots of other state agencies and United Way. Right, we'll be adding the Veterans Administration, the State Department of Veterans Administration. We also have OEC, we have United Way, and excuse me, and the Department of Housing, so that when an individual comes in, and we're primarily serving our TFA clients right now. So we decided that we would start small with our neediest clients and our neediest citizens throughout the state. They can come in on one visit and get an entire array of services met at the same time. Instead of our sending them from one place to another, which is incredibly difficult when you think about childcare and transportation and all of the other barriers that our families face. So we've served those families under this pilot. This is to be able to expand that pilot to some of our other resource centers so that we can do this for more families. The state of Arkansas actually has done this. They have 5 of them that they've done over the last 7 years or so. And those are actually done on a community based manner, meaning that they are seated within the communities. They are separate from their resource centers. In some cases, some states that have something similar to this, like North Carolina, they've actually eliminated the resource centers as we know them, and they've replaced them with this version of the Opportunity Center. So we're actually on doing this on a very small scale. But the families that we've supported have really expressed a deep level of appreciation for understanding how challenging it is to get access to services from more than one place and within the state. We're also hoping to add the Department of Motor Vehicles, and our people also, the people that we support also can have access to the Department of Labor. So it's just one place that you come in, you go from one station to another, or if you're online, we have a system set up where people can just see different people from different departments. That time is just for you. And the dignity and respect that comes with that process, as opposed to the ones that come with you standing in line in a resource center, is really indescribable. And so that's really what we're working on. So this Senator, to answer your question, the 10% investment that we're making is really a very small one when we compare to really where it is that we're trying to transition the delivery of services for the more than 1 million people that receive services through DSS.
Okay. Well, thank you for that. Just following up on Representative Nuccio's question about the MedConnect program, it is my understanding that the individuals, certainly individuals above a certain income threshold who receive these are working adults with disabilities who receive Medicaid through MedConnect, pay a premium to offset the cost of the department, so that the specific group of people for whom there is a potential cost in expanding coverage to DSS is actually at the lower end of the income scale, not to the upper end. Is that correct? And if so, why are you restricting, if you're trying to save money, why are you restricting the expansion to the upper end whose folks will be paying a premium rather than looking at the cost of the program?
So let me make sure that that's correct. So let me bring that back to the working group, because so I don't want to answer that question incorrectly. But it wasn't necessarily based on those that are paying premium at one end or the other. It was really just trying to limit the number of people that would be participating in the program over a period of time. That's really how we made the calculation, not necessarily with the payment of the premium, but I can bring that back to get you more accurate information on that.
If you could bring sort of the
Certainly.
granular information to OFA and the working group, that would
I
be
can.
helpful, because my understanding is that, if you're going to let somebody in at $85,000, they're going to be paying a premium that's intended to offset the cost. So there shouldn't be a net cost to the state. Obviously, that could be incorrect, but
Right.
if that would be helpful to understand. Last question, I see Chair Walker staring at me, so I want to be respectful of the committee's time. The $1 million well, she has a regular question. I just want to make sure I'm not getting into trouble. So the $1 million for care coordination, we've obviously had a lot of conversation about the cost of long-term services and supports. And I know there was a proposal earlier for some version of Medicaid managed care. I just want to make sure that that's not what we're talking about for this population. Who would be, how would that work sort of
Yeah.
specifically? And how do we reassure the advocates out there who have that concern that that's not what
Sure.
the department
No,
considers?
we're not discussing managed care. We had the Medicaid landscape analysis. I think we're all very clear about the direction that we're going in. Our program, our Medicaid program across the board is managed by administrative services organizations. There's one that manages behavioral health, another one that manages medical. And there is it's not necessarily an ASO technically, but there's another that also oversees our, I guess, trying to think about the right word I would describe it, our prior authorizations. I'll just use it that way. So this would be another organization that would help us. I don't even want to use the word manage, but administer our long-term services and support. So it's not about stinting care. It's not about doing any of those. It's really addressing what Rep. Nuccio just said, like what is the most effective way for people to get services that doesn't seem duplicative, right? That is true care coordination that I think we can do a better job at now.
I think we all share the same goal of lowering the cost of especially that population, since we're such an aberration regionally.
That's right.
And you would be using an ASO model. Is that-
We would be using an
Okay.
ASO model.
Great.
That's
Thank-
correct.
Thank you very much.
Yes.
Representative Nolan.
Thank you, Madam Chair, and I'm not going to ask her a question because I want to make sure before I ask my question. Increasing Medicaid provider rates. Did we ask for a list of the providers already? All right, because I didn't want to wait for questions. Very chop over here.
Understood.
Got to be careful. So I'm going to go to the next, reducing long-term care pharmacy dispensing fee costs. And I just want to be clear in regards to this. So right now, long-term care pharmacies can only dispense up to 30 days.
They can dispense up to 30 days, yes, but excuse me, 'cause my allergies are terrible, so forgive me. What's happening is that they are dispensing in shorter increments and then charging the dispensing fee for those shorter increments when they have the capacity to dispense a 30-day amount of medication. So what we're trying to discourage this frequent dispensing when a longer term dispensing really can not only be more cost effective, but really more efficient for the patient as well. So they know that they have the 30-day supply of their medication. So this is to be able to have that dispensing fee only be paid once for the 30 days rather than multiple times for shorter dispensing of the same medication quite often.
Okay. This is not a question. It just seems that it would be important for us to get our seniors 90-day prescriptions so that it wouldn't be so frequent. And so it would save some money since that it's so frequent that we're getting charged. And I just wanted to go back to a question that Representative Gilchrist asked in regards to the statutory inflation. It sounded like we keep doing this every time we get into the budget, where we put a pause on it or don't match what it's supposed to be. So how far are we behind if that wasn't asked? And what should we be at in regards to the amount that we're lacking?
I would have to get you those specific numbers in the working group. So I would say that I would answer the question. I think this is in a similar manner that Nicole Godburn answered, that there's definitely a distinction between making an inflationary adjustment and a rebasing. So I think Representative Nolan, if I'm not mistaken, your question seems to be more based in the rebasing, meaning what should they be getting now? If we had made rebasing changes in the past. Those specific numbers I don't have in front of me. I can get those for you so that we can know. As you know, we did not make the inflationary adjustments last year and the proposal is not to make them this year. What that specific number is, we can also get that for you as well.
Okay.
Okay. They would be different though than the rebasing numbers.
It's just getting a little hot.
Understood.
I'm going to wait my next turn.
Okay.
So I just want to say when we didn't, I want to make sure because I've been pushing back on Secretary Beckham's comments that we didn't do a budget last time. We didn't do a budget last time, but we did pass a budget that in a dollar amount that everybody is talking about relative to that was not included in the second year of the biennium that we supported. We also didn't include the $340 million in interest payments on ARPA. And I'm not saying this to you, but I'm just saying out loud that if we had had that $340 million in ARPA funding interest, we would have been able to do all of the things that have been requested of us, and the critique that we did not include that. That money was kept in abeyance and kept secretly from the legislature. And so I just can't let that pass by. And I agree with you. We didn't do a budget last time frame, but Representative Walker and I went through the budget in great detail, and we outlined everything that needed to have an ability to be covered, to include our ADAC and a number of other things. And we did that, and we gave it to our leadership, and we gave the administration the ability to do that, moving from other funds. So the fact is that we allowed that to happen. We voted on it at the FAC meetings that she and I have been in attendance to, and we were very careful about that. And this is not a critique of you, Commissioner, please. I just am not letting that go by any longer when that is a talking point that we actually addressed very carefully and very consciously. We are not required to do a budget adjustment every year. It's actually not necessary for us to do a budget adjustment every year. If we're going to do yearly budgets, then we should recognize that we're doing yearly budgets. But that's not what we're doing here. We are doing a biennial budget that's in front of us. And if we had been given that $340 million assessment, we probably would not have spent all that money. We would have wanted to add to our more than $8 billion that we have put down on our pensions through the codification of different policies that the legislature fought and passed. And so I just, I'm really not critiquing you, but I can't let that stand any longer. I can't. Representative Nolan, are you all set? Representative Dathan. Thank Representative Dathan.
Thank you, Madam Chair, and thank you, Commissioner, for all your teamwork that you guys have done in the last year. It's really been helpful. It's tough times that everyone's having and a lot of frustrating discussions. At the Medicaid rate informational forum, I had asked the question about our deficiency in Medicaid of about $290 million. And I really wanted to get a breakout of what that encompassed. Particularly, I wanted to know if those things were part of federal match at some level or not, to really understand if it's caseload, because then we have another section talking about adjustments for caseload. And I'm just trying to understand how those two things work. So if you could bring that to the working group, I know it's a large ask, but that would be super helpful.
We can start, I'm sorry, we can answer part of that now,
Okay.
and then we can bring back more details to the working group. And so I'm here with our CFO, Brianna Mitchell, but I can tell you the primary cost drivers for that deficiency is what we call enrollment mix. So that is an increase in enrollment and costs. It's also a change in the prescription drug rebates. So this has been happening over the past several years, where there are specific drugs that we use in our formulary and on our list of preferred drugs. And the manufacturers of some of those drugs have reduced the amount of rebates that we can get on drugs, many of whom our members use quite frequently. We also have had an increase in our home health and home care and our waivers. Right? We saw that in our Medicaid landscape analysis. We do have more people using home health services. That's fine. That's what we want, or we want people staying out of the nursing homes. We also have some what we describe as underfunded mandates. So that would be the growth in our Husky Medicaid program for some of our folks who are not documented, and some other mandates that have been implemented over time. And I'm going to get a list of those as I have them with me.
Yeah.
But Brianna, would you
sorry.
mind? I'm so sorry.
No,
I
no,
didn't
no,
mean to
you're
interrupt
fine.
you.
Sorry, Brianna.
Go ahead, Brianna. You can certainly do that. Yes. And then anything else you want to add? Yeah.
Hi, Brianna Mitchell, CFO, DSS again. Those cost drivers that the commissioner had mentioned are to the tune of $295 million. And again, we can get you greater detail in what each of those line items includes.
Yeah, because I think I just would love to get an understanding, a breakout by dollars of those amounts, and an understanding which are subject to a federal match and which aren't. And then because we were also given another number for caseload that is included in your update current services for Medicaid. So I'm just trying to understand how those all fit together. That's my first question. My second question has to go to your slide presentation, which was really fantastic. I wanted to understand how we have on slide 9, we had the different supported programs, staffing costs, and then administrative cost ratio, that sort of second chart. What I was hoping to get an understanding of, if we can see the sort of breakout, maybe a trend analysis for like 3 years of each of those 3 major categories. So we have staffing as one, operating expensive, and then an understanding of the administrative cost ratio for a couple years in the past, and then within our budget, so that we can understand how those drivers are. And of course, everything goes without saying that we don't know what's going to happen
That's
with
correct.
federal match, but based on your current assumptions. So thank you very much,
We can do
Madam
that.
Chair.
Representative Gonzalez.
Thank you, Madam Chair. Here on the budget, you have Hispanic programs. And I noticed it's a cut. Do you have a list of those agencies and they are getting these fundings?
I can provide that for you. Yes, I can get that for you. I'm happy
Okay.
to provide that in the working group.
Okay, thank you.
Yes.
Yeah, also I want to say that I know this company, this insurance company that provide a lot of services in Hartford and also all over Connecticut. And they dedicated to assisting Medicare beneficiaries. They provide guidance to seniors. They help them apply for Medicare savings program and Husky. So I don't work with them, but they call me, and also the seniors around my district, they call me and they're complaining. Okay. They're complaining. I'm sorry. Do you want me to start again or? Okay. So in those cases, they are required to use a phone to communicate with the interpreter, which can be a problem for them. Other problems they are facing after a long waiting, seniors are informed that no Spanish speaking staff are available, leaving them with no option to apply by mail. What is also can be challenging for those who struggle with reading and writing. And sometimes they end up with problem because they have problem with reading and writing, and sometimes they don't finish the application, so that's a problem for them. Also, this organization are complaining that when new seniors enroll in Medicare and have Husky D, the system often cancel the Husky coverage instead of providing them with the necessary application of renewal for Husky C. So she was explaining me that she thinks there is a problem in the system, that when they apply for Husky D, maybe your staff is not very well trained, so they don't know how to do that. And when they apply for Husky D, automatically they cancel Husky C. So that's the problem. It's a lot of seniors complaining about them. And I understand that maybe, I don't know if you have any vacancy, I don't know if you have any Latino staff, but it seems like it's a big problem.
Well, first of all, thank you, Representative Gonzalez, for that feedback. And I will take it back to our eligibility operations staffs to get to the bottom of what is actually happening. Our staff is actually fairly, many of them are very experienced, especially in long-term services and supports. They're usually the ones that have been with the agency the longest because those jobs are considered promotional opportunities. You can come in as what we call a CCT, which is a Connecticut trainee, and then you move into becoming an eligibility services worker, and then you can move into long-term services and support. So there usually are more experienced staff. There could be a systems issue that we're not aware of that you're bringing to our attention, and there could be some more training that might be needed with some of our staff, especially those that might have been newly promoted. But if you're finding it to be a systemic issue, which is what I'm hearing you say, then I can certainly take that back and have that resolved. Would there be an opportunity for us to be more connected with your office? So I've written down as much as I can so that we can get the details and address them directly. So that's number one. And number two is that our staff at DSS, and I'm very proud to say this, it reflects the diversity of this state. So we have a number of people who are Spanish speaking. We are, but our interpretive services from what you're describing might not be adequate enough, and I need to go back and address that.
So why then, if you said that you have, staff capable to do the job and, they are doing the job, then why give an appointment to seniors and let them wait and wait and wait for hours and then send them home because there's no staff available, no speaking staff available? So I don't think that is right. Seniors, when they go to appointment like this, usually they are nervous because they don't know how to deal with the system. They don't speak the language, they don't read or write. It's a lot of problems. And when they go and sit down for hours and hours, and then they send home without, doing the application, and they end up with a lot of problems because usually they are out of help, medication and stuff like that. So we have to be sure, if you said that you have the staff and they are very well trained, so something is wrong then. Something is really wrong, because if it is one senior that complain, you will say, well, maybe have any problem. But when you have a lot of seniors complaining and an insurance company calling me and complaining because of this, it is a problem.
Understood. We'll address it.
Thank you, Madam Chair.
Thank you. So now we're going on to our second question, and I'm going to ask, I want to go to the update on current services for Husky B, where we are decreasing by 7.9 and 6.7. And so I look at this and it says for children of families with incomes in excess of 201% of the federal poverty level. Do you know what that equates to in a yearly wage?
I do have this chart because I still have to use the chart that explains what the income levels are annually and monthly for different levels in Husky A. So, we do have different categories of Husky A. So up to a family of 6, that is under $64,448.
For
And
201% of
that
the,
is, I think that is not, that might not be our 201%.
this is the Husky B program.
Huskies are, that's what it is.
Say,
Okay.
I'm sorry.
Husky B is 202 to 223, but Husky A is the 201. That's correct.
And so what does that equate to? If somebody's at 201% of the federal poverty level, what is the dollar amount that they're making each year? Do you
Yeah,
know?
so it depends if it's a single person. Pete, I want to make sure I get this right because I have the number of 23. My chart.
Why don't you go to the other chair?
Sorry. I have a chart that we use.
Yep.
And so family of 1, that is under 23,000, and up to a family of 6 at 64,000.
So
That's for the Husky A parent and caregiver relatives.
what about the Husky B program?
So Husky B for a family, for a single person, that's between 29,307 and 37,033. And for a family of 6, it can go up to 102,000 $228,311 under Husky B.
Under Husky B, and that covers the 201 to 323% of the federal poverty level.
That's right.
So there's been a lot of talk about Husky B relative to the prenatal services for pregnant women under the unborn child option, as well as the state-funded coverage for children ages 15 and under, regardless of immigration status. And our understanding was that when the numbers were first coming in, that there wasn't a clear way to tell whether someone was documented or undocumented, and that the numbers were skewed. Is that your understanding too?
When we first began, it was. And so now we have made, and I think Deputy Commissioner Hadley is here to continue to answer this question. We've made considerable efforts to make sure that that is cleaned up so that it's more reflective of the individuals who should be in one bucket of those that we provide coverage for regardless of their immigration status, and those that are covered under our Husky program that have a documented immigration status. So we do have that. So that, but at the time, we didn't, we needed to.
So
fix
the
that.
numbers that were being reported out were not accurate.
Not at that time.
Right.
No, but we've moved people over since that time. But I'll, if you don't mind, I'll defer you
Yep.
to Deputy Commissioner Hadley, because that work's been happening under his watch.
Yep. Thanks, Senator Ashton. Peter Hadler, Deputy Commissioner at DSS. As the Commissioner just outlined, that is correct. They were overstated for the recent past. We did identify some issues where the system was, in certain cases where we didn't have clear documentation of someone's citizenship status or other piece of information, the system would default them into the state-funded coverage because it was sort of the catch-all for folks who didn't have that documentation clarified. As we've gone back and looked at the population that's enrolled, we've identified there's quite a few citizens and other children who belong on the Medicaid, full Medicaid side of the house, and we've been working to adjust those numbers accordingly. So we are moving folks who are counted in the state-funded program onto Medicaid where it's appropriate, where in fact we do have information that confirms their citizenship status. And so, yeah, the enrollment numbers and the expenditures in that program have been lower than reported.
So have you gone through all of the people who have applied for Husky B to ensure that the numbers are now accurate across the board?
It is still a work in progress. It is not completely done, but we have done, I would say, about 80 or 90% of the work. We've automated as much as we could, but some of these are very complex cases that have to be gone through one at a time to ensure that they're being put in the right group. And when we do, we ensure that they're retroactively covered under the appropriate coverage as well.
Because if they're covered under Medicaid or Husky B, that is covered currently by the federal government, we're getting a reimbursement from that. Is that true?
That's correct.
That's right. We can apply for reimbursement.
And your numbers for again, I just want to make sure I heard this correctly, 201% to 323% of the federal poverty level on a family of 6 is up to $102,000, a family of 6.
Right. So we have 3 bands of Husky B. So the first band is our Husky program and children 0 to 12. And that, if they're enrolled through 18 before they turn 13, that's another category. That band can go as high for a family of 6 to $102,311. And then we have our Husky Band 2, and that's for our kids that go also through 18. And that can be as high, that actually has a monthly premium associated with it. That's the second band. And that can go as high as $130,104 for a family of 6. And then we have our Husky Prenatal for non-citizen pregnant individuals and their unborn child. And that for a family of 6 can be under $105,936 with no monthly premiums.
There's a premium on the second one, but there's not a premium on the other two.
Correct. That's correct.
And if you could bring all of that data to us in the working group.
Yes.
And I want to go back to this. I want to make sure that people, because there was an article that came out that said that we were spending $1.3 billion on undocumented people in Connecticut.
We are not.
Are you spending $1.3 billion on undocumented families and children in Connecticut?
We are not.
So
No.
I can say to people when they call me and write to me that was an inaccurate article, that it did not include the correct data at all. So it's not $1.3 billion being spent on undocumented people in Connecticut. far less than that.
That's correct.
Looks to me like it's far less than that. Can you bring us the actual dollars
We
that are
can.
being spent on the
Yes, we can.
undocumented? Now, that still may not be accurate because you haven't finished going through that. Is that correct?
Right, so it would be off by about the amount of money that the amount of money that is equivalent to the children who we're still recategorizing based on what you heard Deputy Commissioner Hadler said. But even with that recategorization, we are nowhere near $1.3 billion.
Are you at 1 billion?
No,
Are you at $500,000?
$500,000,
Yeah,
half a,
500 million. I'm sorry, half a
No.
billion.
no, we're nowhere near that.
So,
No,
all right, can you bring us the numbers?
Yes,
Because
we
I
can.
want to know, because
absolutely.
we started this process to help children out with healthcare. That's
That's
what we
right.
started this process with. I was talking to someone on healthcare today. And I think part of our problem is we have an awful healthcare system in Connecticut relative to the fact that we have people that are teachers and police officers who have these crappy there's no other word for it. There are other words for it, but I'm not going to say them out loud.
Thank you.
There are crappy healthcare systems that people have high deductible systems that can't get healthcare unless it's catastrophic care because we have these high deductible plans, which I disagree with us having any high deductible plan that in any boards of ed, because quite frankly, Representative Walker and I, while vastly criticized, put $150 million into education last year, just in regular education funding, never mind the amount of money that we've done in schools of choice. And over the last few years, we have put in over $500 million into supporting education. And yet some groups have given us an F rating relative to whether we care about education or not. We are beyond done with people saying we're not going to help out, and we need to have them held accountable for getting crappy plans for the workers that they represent. So I would like those numbers, if you don't mind. That is my last question for today. Representative Walker.
Thank you, Madam Chair. Commissioner, when we see a deficiency in the comptroller's report for you for Medicaid, is that the actual amount or cost that the state is being charged? Because I thought I had heard that we are on a lag system, so we are paid in the rears. So
That's
even though we have $295 million in a deficiency, that we have not received the last payment, so we're still on the catch-up. Is that true?
It is true to a certain extent, but with respect to this particular deficiency, it is actually a more accurate number because we have seen an exponential growth, particularly in pharmacy. And that is really one of the main drivers of our deficiency. Enrollment has creeped up over time, and the amount of services that people access has also grown over time. And we are seeing people, when they can get access to a specialist, seeing more specialists, and that is definitely more costly than average primary care. But our primary drivers are really pharmacy. Yes. So
Okay,
there might
and-
be a bit of a lag, but it's not a $300 million lag.
It's, okay,
No.
it's, I'm sorry, say that again, I didn't hear it.
There might be a bit of a lag in terms of getting our federal reimbursement, but it wouldn't account for the full 300 million.
So
That
it'd
is
be
definitely
half?
spending. Let me get you the exact number of what it
I
might
would
be.
like that.
Yes.
And then when they declare that, are they accounting for the match that we are getting, or is that kept in another account so we don't balance those out that way?
I think they're accounting for just our state spend. It might be the match as well, but let me confirm that.
Please.
Because I thought it always included the match, but I want to be sure.
I think it didn't, and that's the problem. So we get mixed quotes.
Yes,
I won't say misrepresented, I'll just say mixed quotes, okay?
got it.
And on the pharmacy, just quickly on the phentermine and I forgot the other one that you, the key to that is, the problem is that they've been around for a long time and they have not worked. And now we're transitioning over, and obesity is a problem, but it's more than just too much eating. It's also glandular and everything else. And so what we're doing is we're choosing what things we will pay for to save somebody's life. And I resent that. I really do. It's really, the only other one I was going to ask about was the it's in your, there was the facilities that I think, represent, Senator Lesser was talking about, the opportunity centers.
Yes.
Okay, help me understand, what's the difference between them and community action agencies?
Yes, so community action agencies do a lot. Some of them will do some of the same things that we're doing at the opportunity centers, but they also do much more. So they process LIHEAP applications, which we don't do. They look for local services for individuals, which is something that's not done at an opportunity center. They also provide direction for food, and we don't do that at the opportunity center. So those are just three things that immediately come to mind. I will say that we met with the community action agencies recently, and they posed a very similar question. And actually, we are going to try to find ways to always be more collaborative. And the other issue, and I raised this also very respectfully with the community action agencies, we have 1 million people in this state that rely on services. So we need more than one door to provide supports for people. And we want to do that in collaboration with our community action agencies. There might be some overlap in what we provide, but if we have the folks at our door, we want to be able to provide them the support where they are. So there's no displacement of anything that the community action agencies are doing. It's really a supplement to support the significant need that we have in the state.
Thank you, Commissioner. And I wanted to make sure that, because I know as we go through the budget process, I'm going to hear, why are we spending here and we're spending there? We forget that our state is much bigger than just a, we have more than 3.5 million people. So I don't think we're going to have people stepping on each other to provide services. I think if anything, we need to go the opposite direction. So, next is Representative Chu.
I never know which mic to turn on. Thank you. Before I ask my questions, I think a common theme, and I think I asked this in the subcommittee, is there a way for us to get from DSS, like a list of, for instance, I know there are different federal matches for different things in Medicaid, right? I would like to understand everything that we have that has a match, the total dollar amount that we're spending, what is the percentage from the government, and then what is the state portion? If we can get that in some sort of Excel file,
Yes.
I'd be extremely grateful.
Yes.
Okay, the next question that I had is in relation to other services. We're adding 7.8 million in 1 year and 10.4 in the next year. And it just says primary support contract and system stuff. Can we get that broken down?
Yes.
Please?
Yep.
Okay, and then I have some questions around the Medicaid number. I had to step out, so I'm assuming you guys said you would have the exact number for the illegal immigrant healthcare number if we have that.
Yes.
We're gonna,
Yes.
okay.
Yes.
All right, and then the other question that I have is when I look at the current services for Medicaid, I know we're the 290 over right now. And then it looks like in full year 26, we're adding another 90, but then in 27, we're adding almost 250 million more.
Mhm.
Can you give some detail on what's driving that? Why are we expecting, like, I understand the 90 medical trend, you know, I spend my days looking at stuff like that. So
Right.
that makes sense, but to jump another 250 million in year 2 has me questioning why.
Yeah. So in part, it's a bit of a cushion because of the uncertainty that we are facing at the federal level. So the idea is to try to budget at least some dollars for now, not knowing where our FMAP is going to actually land. So that would allow us to have some more flexibility in the manner in which we would, as Senator Austin said when she was here earlier, that we might have to redesign our Medicaid program to actually meet what our new allocations will be from the federal government. I don't know what that's going to look like. I don't think any of us really do. And we also expect that there may be some more growth in long-term services and support. So that's really the other big driver. Because as we watch the trends of people who are aging year over year, we expect that the number of people that we will support who are over 60, 65, you know, as the number continues to go up, will grow. And so part of that dollar amount is to also be able to provide more supports in that space for long-term services and support. So it's a little bit of both.
Do you think you can bring what you're putting in there as cushion? Because while I agree we have to kind of look at that, I'm trying to take a more scientific approach to this. 'Cause,
Absolutely.
you know,
Yeah.
I hate no offense, I hate
understand.
hearing we're putting money in just in case.
I
Right?
understand.
That's like, as an accountant and a fiscal conservative, that's always a little concerning.
Yes, it's primarily driven by what we think is going to be the growth in LTSS.
Yeah, I'd like to understand that, the
Sure.
difference between those then.
Sure.
And then in the temporary family assistance, this year we're lapsing 6.3 million from what I understand. And next year in the budget, it's coming down by the $741,000, which I think is, that's assuming we're gonna have a $6 million increase year over year.
Mm.
And then we have an additional 3.5 million in 2027. And from what I understand, we've been lapsing in temporary family assistance for a while. So can you give me like the assumptions on what that growth looks like there?
Yes, I can.
Okay,
Yeah.
all right. So if you can bring that to the work group, then I think
Yes.
that would be, that'd
Okay.
be perfect.
Mhm.
Thank you.
Next, Representative Gilchrist.
Thank you, Madam Chair. Thank you again. I have a question regarding the state-funded home care. In the grand scheme of the budget, cutting 400,000 in the first year and 500,000 in the second year doesn't seem like that much in our big budget. But I guess what I'm concerned about is what is the income level for the folks who are eligible for the state-funded home care?
Mhm.
Because my fear is that a 3% to 5% jump for them might actually be a significant
Be a
impact.
significant one. Yeah, I don't have those specific numbers. I do have with us Christine Weston, who administers the program. If you didn't want us to bring it back to the working group, she can answer some of the questions today, if that's helpful to you.
You could certainly bring it back to the working group.
Okay.
Would just love to know how many people are on this program, what the
Sure.
income eligibility is, and then, what that 3 to 5% increase looks like for them monthly. I do see there's a monthly cap, but,
There is of 175.
and then just for the work group, Rep. Walker made me think about it when you're talking about the opportunity centers. I'm thinking about the call centers.
Hmm.
And I know in MAPOC, which some people are not a part of, we talked about, I believe it was ARPA dollars that had covered the call centers. Can you just bring an update to us on where we are in terms of how much funding is going to the call centers, ARPA versus state dollars?
Mhm.
What the employment level looks like, what it was or is now, just so folks on this committee can get a sense of where we stand with
Yeah,
the call center.
I can give you a little bit of that now and then bring some more detail to
Right.
you.
I'm gonna say, because we're gonna run out of time and your
I'll bring it
list,
to the
it just
working
keeps
group.
going and going and going. And
Yes.
so I apologize.
Absolutely. I'll bring it to the working
Thank
group
you.
then. You're welcome.
And I'm all set.
Okay. Representative Datham.
Thank you very much. And this is just for the working group, so you don't need to answer today. We were given a update from DSS February 4th. And in that update on page 9, figure 1, there was a whole bunch of trends on the different Husky programs. And I know Deputy Commissioner Hadler had mentioned that there was some updates. Are we going to get an update for this chart as well, as a update to the 2024 numbers? Because, we took a cut in Husky B, for example, but I'm seeing an upward trend in Husky B all along, and I'm just trying to understand how those numbers are. And then my second question for the working group really has to do with the autism wait list. I know we had some shuffling around of reporting mechanisms for that, and I would love to get an understanding of how many people are on the wait list for those services and which services they are on the wait list for, whether it's for day services, residential, or other sort of services.
We
So
can
that's
provide
it.
that, of
Thank you
course.
so much, Madam.
Thank you. And I just want to say to my colleagues, we are asking for a lot of data and a lot of information, which is going to take a lot of work. So I better hear about that stuff when you argue the budget for them. So just want to point that out. Senator Lesser.
Thank you, Madam Chair, and thanks again, Commissioner. In the budget last year, We restricted Medicaid. We kicked a lot of folks off of Medicaid, the Husky A parents, with the idea that they would be able to receive services through Covered Connecticut. I understand that Covered Connecticut's future is now in some jeopardy due to the potential expiration of federal premium support tax credits. What's going to happen to those Husky A parents that we promised would get coverage? And what can you talk about the future of Covered Connecticut and what DSS is doing to support the program?
Thank you. Of course, when we proposed the change, no one could have anticipated what is happening now. So we are exploring with Access Health and with and also with the new owner of of the two, well, I think I'm talking about Connecticut. Sorry, talking about Connecticut. And we're also talking to the new owner of Connecticut, right? Because it's been taken over by another another insurance company as to what we can do. So at this point, we're exploring with Access Health where any of those families might be able to transition onto any of the programs that we offer under any of our plans, right, on our exchange. For families that cannot, we continue to try to find resources for them because Covered Connecticut was supposed to be our resource for them. So we're still working on a solution for them, but I don't have a full solution for every family right now.
So my understanding is that the cut has not gone into full effect
That's correct.
because there's that delay that's baked into the Medicaid program when you are
That's correct.
restricting coverage.
That's right.
So is there any thought, I don't see anything in the budget, to not pulling the trigger and allowing those tens of thousands of residents who would lose their coverage otherwise on Husky A to stay on the program, since there may not be a Covered Connecticut for them to
Certainly,
transition to?
certainly, that's definitely one of the options that's being explored. Yes, I'm sorry I didn't fully articulate that, but of course, yes, of course.
Okay, could you get us some data about the what we would need to do in the budgets to
Yes.
actually do that? That
Yes.
would be very helpful if you can
We
get
can
that
do
to the
that.
subcommittee. And then just general information on Covered Connecticut. Thank you.
Sure, absolutely.
Thank you. Representative Dillon.
Commissioner, thank you very much for your presentation.
Yes, thank you.
I have just a very quick question going forward, which I don't know that you ever would have been dealing with yet. It is my understanding that the administration in Washington is banning the use of telehealth for people on Medicare. And I don't know the details of that. I had just gotten an alert about it on Friday. I wonder going forward if you have anybody in your network, because you have obviously people in nursing homes and so forth. I'm concerned that there may be reduced access to people with disabilities and people in some of our facilities. And I don't know all that, but I wonder if there's somebody in the department who could put together some way of assessing that and making sure that our folks don't lose access.
Yes, we can. We just learned about it on Friday as well. And it's challenging because we do have a number of people who are in long-term care facilities who get access to even behavioral health services through telehealth. So it's very challenging that there's this restriction, but we just learned of it. So we can come back to the group with some options as to how that might be addressed.
Thank you. I'm sure we'll
Thank
talk about it again, but
Okay.
I appreciate it.
Thank you. Representative Nolan.
Thank you, Madam Chair. Just following up on something that Rep. Gonzalez mentioned in regards to the Husky D and Husky C. Are the trainings in regards to that
Forgot about this.
with the same persons, or are they separate departments for those two?
No, it's the same. Yeah, it's all eligibility operations. So it's the same department.
Okay. And the training, the clarity on the training, so that when they do talk to people on the phone, they understand the difference in the two enough to not get them confused as in was stated.
They should. And so, what Representative Gonzalez has raised is concerning, and I'm actually going to bring that back to the Deputy Commissioner that helps to run eligibility operations so we can get some clarity as to what's occurring and address it.
Thank you.
Yes. Yes.
Thank you. Are there any other questions? You have a question? Representative Martinez.
I know there was questions asked earlier about the reduction in overtime.
Yes.
And you had stated that hours of programs, they didn't need to close earlier or anything like that. I'm just wondering if you've had feedback about the quality of programs and services with the reduction of overtime?
So yes, it is challenging for us to continue to keep up with the volume of applications that we get. You know, there are certain standards that we need to meet for our federal partners. For SNAP, we have to meet certain levels of timeliness for SNAP application, not only approval, but also getting the benefits out the door. And also the same is true for our Medicaid applications. It's very challenging to do that within our limited overtime budget, but we do have people who we think are really trying to do the best that they can. We also had additional access to some ARPA dollars for our call center that we no longer have access to, and I'll bring that back to the working group so I can provide you with more detail. But it is very challenging.
Thank you.
Yeah.
And then at the last public hearing, I had asked about the medication administration rates.
Yes.
And I had spoken with you specifically about comparing Connecticut to Massachusetts because they're utilized very similarly.
Yes,
And as I understand it, currently the Medicaid directors and rate setting staff is reviewing that.
that's
Um,
correct.
So I was just hoping to have that information for the work study group, as long as information pertaining to the subsequent rates and the administrative adjustments.
They are working on it, Representative. I'm sorry for the delay, but they're continuing to get that together.
Thank you.
Okay.
Well, thank you, Commissioner. Thank you for your answers and your thoroughness, and thank you for your patience with us.
Certainly.
And
My
you
pleasure.
never lost your cool, even though there were some silly questions in there. I heard them too. So thank you very much. And I
welcome.
thank your staff too for supporting us and trying to help us understand how complex your agency is and how important it is for all of us to sort of know how you operate. So with that, I thank you. And I had, one last one. I forgot
Certainly.
this one. Well, you can bring it to the group, but you know I'm asking about FQHCs and
course.
where we are. So
Yes, of course.
I had it written down and I didn't get to that paper until just now.
Yes.
So thank you very much. Everybody have a
welcome.
good day.
Thank
Thank you. Next, we are waiting for the Department of Children and Families. They are up next. They should be probably coming in, hopefully momentarily.
Madam Chair, you're on a lunch break from 1 to 2. Department of Children and Families will be here at 2 p.m.
It says on the program that we're looking at, it says 1 to 2 Department of Children and Families, Madam Administrator.
Well, that was a typo by the administrator.
Okay. No, it will be okay. So we get a lunch for now? Oh, goody. Thank you.
Commissioner, you can go ahead and take a seat. Good afternoon, everybody. We're going to call the meeting back to order from which we were recessing before. And all of us were confused because in front of us sits a sheet that says 1 to 2 you were coming in. Then I saw you downstairs. I thought we were going straight through, but we were not.
We're good.
We were good. We all needed to have food. That's why I went down and got food because I thought we were going straight through.
We were suffering.
So, so Commissioner, do you want to make a couple of opening statements at all?
You can just say, hey.
Thank you. With your permission, I'll be very, very brief. I'll
Very
do
good.
my salutations to, and say good afternoon, Senator Austin, Rep. Walker, Senator Summers, Representative Nuccio, and distinguished members of the Appropriation Committee. I'm Jody Hill-Lilly from the Department of Children and Families, and I thank you for this opportunity to testify in support of the governor's proposed biennium budget for the fiscal year 2027. And I have my amazing team behind me here. And I wanted to announce that you all know that we had been in flux with a CFO. And I'm happy to announce that we did hire a CFO finally. And his name is Steve Francis, and he's in the audience. And I'd like for him to just raise his hand and say hello to you all so you could see him. And I have my acting CFO, Olga Coleman Williams here, who has been amazing, faking it all this time. She's doing a great job, and we ask that you have just a little bit of mercy on us.
I don't know. We're trying to try to have some mercy, Commissioner, but you know, it's kind of hard for us to understand where mercy is these days.
That's true.
So,
Fair point.
So I have a couple questions, and I just want to go to the juvenile review boards, and in your request, you are asking for $6 million each year for the juvenile review boards, which is on the page 15 right at the bottom. And the governor recommended giving you $3,897,957 and a little bit more than $6 million in the year 2. So that's a cut of $2.1 million, give or take. What is that reflective of, that $2.1 million? Does that relate to the delayed implementation of the pre-arrest diversion plan, or what is this?
Absolutely, you're spot on. As you know, we wanted to do a comprehensive landscape analysis to make sure we're fixing the right problem and implementing our plan as fully as possible. And it's taken a little bit of time to get that off the ground. I think we are nearing our finalization, or we have finalized our recommendations, and we don't see that being an issue going forward.
So, so you don't need the money this year because the implementation of the plans for pre-arrest diversion is not starting in the next biennium. It's starting in the fiscal year 27 biennium.
That's correct.
Thank you for that. I just was trying to make sure.
26, I'm sorry. Half in 26, I'm sorry, my folks are here. Half in 26.
And then the full year in 27.
And the full year in 27. Correct.
Okay. Thank you for that, because I wanted to make sure I understood what was going on here. Because I see the cut of 2.1, and then I kind of hard to figure out if that is relative to an increase. And last year in actuals, it was 1.7 and appropriated 6 million. So that you probably didn't spend all 6 million in the current year that we're in.
That's correct.
Okay. Thank you for that. So I just wanted to make sure I understood what was going on. And you reduced, you may not have reduced, but it has been reduced $18 million in personnel services. Is that, were you lapsing that dollar amount, 18 million?
Yes, historically, we had, as you know, been impacted by our workforce when we had the retirement in 2022, and just folks really deciding that this work is too difficult for them. And so we did lose some staff, and thank God we're at the point now where we're starting to fill positions. But and you may or may not remember that DCF's budget is personnel staffing counts are contingent upon the caseloads. So as the caseloads go up, the staffing needs to go up. As the caseloads go down, we have a reduced need for staffing. So for a while, we had really low reports, and that was happening all across the country, where after the pandemic, there were few reports kind of coming in. And so those positions were sitting vacant. And so that's reflective of some of that.
So I just want to tease that out a little bit more. So you are seeing less of a need to fill $18 million worth of positions. Are you going to see that need go back up to need that $18 million next year?
I wish I could predict the future, and I wish I could say absolutely not. But the way things are, you may hear me saying that, you know, the pandemic is over, but the complications from the pandemic and the mental health acuity and the things that we're seeing among our kids and our families has been quite complex these days. So I can't predict what the future is going to be, but what I have been able to say pretty comfortably is that the Office of Policy Management has been responsive to our needs when we need them, when we need the support. And we've built in a little bit of buffer for when the cases rise again.
So this is not cutting you to such a level that you're not going to be able to respond to an increased need.
That's correct.
Thank you. Representative Walker.
Thank you, and thank you, Madam, for your presentation or testimony or both, whatever. I'm gonna go right to something that I saw that I'm a little concerned about. The opioid settlement fund. The opioid settlement fund says that the governor is going to provide 8.6 million in 26 and 27. And it's for in-person pediatric mobile crisis intervention. Have you submitted a request to the opioid settlement fund?
I don't know if we've technically done that now. I have Frank Gregory here who would. No, we have not submitted a formal request as of yet.
Okay, because that's supposed to go through the settlement committee.
Yes.
And
the
I think the question I have, or the concern I have, is I'm not a big fan of mobile crisis, because mobile crisis is a temporary fix and it doesn't really address some of the healthcare problems for a lot of these kids is really ingrained and needs more than just a one-shop kind of thing. So I look forward to hearing from that in the committee, because we have several different mobile units that we have purchased or authorized, but they're mostly for methadone distribution. So this is something unique, and I'd really be curious to know about that. So I'll keep my eye on that one. My next one is the one which I don't know if you watched the hearing before with DSS, but I questioned the IT transfer, and I questioned it with DSS, and the commissioner had a really good response, because I think she addressed part of it by saying this is going to help us with purchasing of software and management and infrastructure of the hardware that we're doing. However, her concern is, which is also a concern that I have for DCF, is the fact that both of you have case management systems. Both of you have unique systems that are important to your agency to operate for your caseworkers and everything, for documentation, for follow-up and things like that that need to go, excuse me. And those things are unique. Nobody else has them.
Mm.
And the other part that I worry about is private privacy, because of the fact that depending on the number of people that are going to have access to it, it's another problem. So I would, what is your opinion of this transition?
So first, let me say that our person who acts as a liaison to us, his name is Eric Nixon. And when I say he's a superstar, he is a superstar. He was an employee of ours before the transfer, before the centralization movement first started. And he's been wonderful. He's a great asset to us. He's a fixture in our offices, and we meet with him regularly. So far, so good where that's concerned. You are absolutely correct that we have a legacy system link that we're hoping to sunset and implement our CT Kind system. And we have a staff
Link is
in-house.
the only system that I know of that has been out longer than me. Just say, like 96, I started a few years later. Go ahead.
And unfortunately, it's a commonplace in child protective services that there are these legacy systems out there. In fact, and federally, there is not, I don't believe there's one state that is compliant with the federal expectations. So it's been a long haul for us, but I think we're almost there. We're almost over the finish line. And guess what? The implementation date is August 7th, which is my birthday. So
Party.
we're about to make this happen. That's
So can you just explain to me the difference between Link and what was the other one?
CT Kind is where
CT
we're
Kind.
going.
Okay.
It's more agile. It's, cloud-based. It's easier to manage right now. The legacy system is very clunky, hard to get data out of. If you ask for a report, it might take hours to get a report versus a click of an easy click. It's very, very time consuming for our staff who are already, taxed with all the work that they have to do. They do double the work with the system that we have. So it is time for us to launch this new system.
I know that, we've had Link for a long time, but it never gave us the type of data or opportunities to actually, and it's funny, you hear a lot of social service agencies talking about evidence-based. We could never prove evidence-based because we didn't have the data to say it. We can prove it. So it keeps us out of the mix that we're supposedly trying to strive for. So so saying that to say this, I said to DSS that it would be nice to have a little sit down with DAS, with DCF and DSS to talk about not necessarily giving up 30 positions, maybe 15, but you keeping half of them to maintain that infrastructure for data. Because as long as we don't have accurate data and access to it, we will always be in the 1960s with Link. So therefore, we need to evolve. We also need to create our own. I'm so tired of going to places where they all have evidence-based programs. I want to say we have evidence-based programs too, but I can't because I can't actually cite the data that's necessary for it. So I think to bring Connecticut into the 21st or 22nd or 23rd centuries, whichever one you want, anywhere going forward, we need to have data. And so I hope that we look forward to having DCF and you guys together to have a compromise on a shift in personnel so that you guys can get into the same situation that we all have in that. And then I will also go to the question that Senator Austin had, which was about the juvenile review boards. I see the cut, and I do remember hearing about some of it, but I thought that the cut was going to help supply services in other areas of DCF. I thought it was going to be transitioned to other areas. I didn't know it was coming directly out. So I'd like to understand how you came up with that number and what is being left so that we know what we're doing in that line item for the group. I don't need it now, but I'd like it then. But if I have more questions, overtime, my favorite. Um, so I looked at overtime for you and I looked at, overtime over the time. There is a lot of overtime. I mean, it's interesting, mostly all our social service agencies have overtime. DEMIS, DDS, DSS. I mean, the only one that I don't see there is really DPH, but DPH is almost all federal dollars, so that's a different story. So in your overtime, you are increasing. And this past year, it was a major increase. So can you just explain what you think is going on with your overtime?
Absolutely. So even though we're better in terms of filling some of our vacancies, we still have a little ways to go. And whenever you have
What is your authorized position count and your paid for position count?
you can.
Our
And
authorized,
who are you?
I'm sorry. My name's Olga Coleman Williams. Currently, I'm Assistant Chief for DCF. I was for the last 5 months the acting CFO.
For the last one. Change those chairs, change too much. Go ahead.
Absolutely. Our authorized count is 2974.
And your paid for count?
Our paid
2974.
Yeah.
How much?
The same
number.
amount. The same.
2974.
And you have all those positions are paid for?
Yes, they're full.
Huh? How many are filled?
Oh, how many are filled?
Yeah, let's try that one.
2846.
Okay. Okay, so those are filled. Okay, thank you. So I go back to my question. Overtime.
Yeah, so we still have some vacancies. It's generally in our hospital settings where we're much, much, much better in terms because we changed our nursing model to include LPNs that yielded tremendous results for us. But we still have a great deal of turnover and we're still struggling just a little bit to fill some of those positions. So you'll see that the overtime numbers are a little bit higher in our hospital settings because of that. Same thing with the social worker positions. The work is tough. It's very tough. The work, we're seeing high levels of acuity of the families that we're serving. And it was interesting. I was at a staff meeting not too long ago, and one of the newer staff said, Commissioner, can you tell me why I should be incentivized to stay here when, the work is so tough, and I could go somewhere else and make more money. And what was interesting is another social worker in the same meeting stood up and said, well, it's what we do. It's the value. It's our contribution to society, and just it's when you're called to kind of do this work, you stay in it. So it was an interesting to watch them talk to one another. But the reality is the stress of the job is sometimes outweighs what a person can contribute based on what they have in their own lives. Because life is life. Whether you're a DCF social worker or not. And so we've seen changes in our turnover, which means that the overtime goes up.
I think the thing that people don't realize is how dangerous it is for your caseworkers, because if you think about it, going in and taking a child away from a family, or going in and telling somebody they have to leave because they're not allowed to by court order, it becomes a real challenge at that time. And I've found out, I checked, you guys do not get hazardous pay.
No.
And you're not high on the salary scale either. We really need to, because I know there's another group of people in the legislature that are looking at visiting nurses. And I liken you guys to visiting nurses in many ways, only a little bit more, because the visiting nurse can walk away with the family out the door. And that's a challenge to the family security. So I want to find out what your time element, what your expectation for a person in that position, what your starting salary are, And how many members do you have in your workforce that are frontline that are actually there for a long period of time, or how many you're actually turning over quickly? You can tell me later, because I'm tired. But anyhow, I'd like to know that. I shouldn't have said that. But I really want to dig deeper into this to see, and that and foster care. I want to get into foster care and what we are paying and how we are coming, because I know our numbers in foster care are really far down. So I'll stop there.
Can I just acknowledge your comments? And literally, I was talking to Tina Jefferson, the Bill Chief of Child Welfare back there just a minute ago. And we heard the testimony of a worker who got locked in a basement of a family's house for hours.
Wow.
This is the kind of thing that happens to our workers.
Do you
farms.
keep track of all the incidents? That
Oh,
take
yes.
caseworkers?
Oh, yes.
So do you have incident reports that you put together?
Absolutely, we do.
So could we get some information from the incident? We'd like to see those things. I think they're kept quiet all the time, and I don't think we should allow that to happen, especially since these are people from Connecticut that are in there. We've closed a lot of hospitals and a lot of mental health facilities, but that didn't stop them from having children. So a lot of those things we're seeing more and more each time. So we've got to figure out how to do this and maybe look at some other states. So thank you, ma'am.
Appreciate it.
Up next is Representative Nuccio.
Thank you, Madam Chair. And hi, Commissioner. How are you?
Good. Good
Good.
to see you.
Good to see you too. I have a couple of questions. Nothing too big here, but I noticed in here you have the funding to reflect delayed implementation of the pre-arrest diversion plan. It's about 2.1 million coming out in year 1, and then it's flat in year 2. Can you tell me a little bit about why we're delaying this?
Yeah.
So there, JJPOC is a working group, and it's built very well organized and has subcommittees. And there was a lot of work that happened in the subcommittee, and they did the landscape analysis. A lot of sort of assessment went into what was needed, and it just took a little longer than expected. So that was the reason for the delay. We now have our final recommendations, and we'll be able to implement, which is why it's restored to the full funding.
Okay, so it's just going to be a partial delay into next year till we get it up and running, and then
Correct.
Okay, perfect. Thank you for that information. Excuse me. In regard to the relocation of the voluntary care management wraparound funding, I noticed in this account you lapsed about $500,000, about $500,000. Excuse me. But it looks like we're removing $4 million from the board and care of children. Why are we removing more than the lapse? And do you think this is a sustainable reduction? Do we have enough data to show that we should be removing $4 million from the board and care for children?
Yes, thank you for that question. Over the years, we have done, I would say, a really good job trying to make sure we keep children at home and not in foster care when necessary. And what was happening is that essentially we were moving money from board and care to our prevention SID, which is where this is coming from, because we feel that if we can wrap money around in services around families to prevent the need for removal, it will help us in the end. It helps the family, it's less expensive, all of that. So because we were asking so many times to move money from the board and care to the SID, we just decided to just make it official rather than having to go to FAC to move the money.
Okay, so the community care program is more about community resources to keep kids in?
That's
okay,
correct.
and I have to ask a question just from prior experience. Who do we have working on the determinations on whether it's best to keep that child in the home or to remove them because of a toxic environment there?
Thank you for the question. So as you know, we have assigned social workers that work with families routinely. We also have with us, and we're blessed in this way in Connecticut, that we have clinicians, what we call the regional resource groups. And so we have experts that actually staff the cases and help the social workers make decisions. And that includes lawyers, people with expertise in IPV, mental health, substance use, all of that. And so it's not a unilateral decision. It's a decision that's made by a bunch of professionals. And we have a required meeting before we remove a child from a home. It's called a considered removal meeting. And where the family can come to the table and where we have the experts weighing in on whether or not, one, we have legal sufficiency to remove a child and whether or not it's in the best interest of the child and the family to remove a child.
Thank you. Thank you for that information. And then the last question that I have is in regard to the opioid settlement fund dollars. It says that it's about 8.6 million that's going to go in to maintain the statewide 24/7 in-person pediatric mobile crisis intervention response. Does that include the urgent care centers?
It does not. This is for the emergency mobile itself. That line item is specific to
So
emergency
this,
mobile.
we're saying it's 8.6 million to run additional to run the 24/7. Do we have a total cost on what it is for the program?
I don't know that I have that here. I don't know if Frank has that, or we can save it
Bring
for
it
the
to the
working group.
subcommittee.
Okay.
That's fine. And I thought I saw something in here. Do you know where the urgent care centers are being funded? And that's DSS, is it?
Medicaid.
It's through, DSS.
Medicaid.
It's okay.
Mhm.
All right. I just wanted to make sure. All right. Thank you very much.
Thank you.
Senator Lesser.
Thank you, Madam Chair. And Commissioner, good to see you. Just one, I want to thank you for keeping your commitment to not close the Middletown DCF office. You made that commitment and you kept your word. Thank you for that. Just wanted to get an update. I know we've had some discussions about staffing and overtime. Can you specifically get to the subcommittee just an updated staffing information about the Solnet facilities? I think that would be
Absolutely.
okay. That would be
Absolutely.
Thank you very much. Just with regard to the cuts to OE funding, I just wanted to understand that a little bit better. Could you just explain how those cuts were achieved, are supposed to be achieved?
So in terms of our OE, that generally the expense related to the reduction of those BITS positions, those are representative of generally the consultants who assist us in terms of what we're trying to build in terms of CT kind. So a portion of that is what you're seeing in that reduction with that move to DAS, those represents those positions. But it's offset by certainly the Middletown having that area office back into one of the area offices for DCF, as well as other expenses, which includes inflation, the cost of our fleet, those increased costs that we are assuming as an agency. So that's where you see where it's about a 3.5 reduction because the offset of those two things result in that 3.5 reduction.
Okay, great. And I know there's been conversations about the urgent care crisis centers, but I know that there have been a number of programs through DCF that have been supported by ARPA dollars. Are all of those programs being sustained in the budget? Are there some that are not? Could you just give us an update about where we stand in terms of
So I
expanded
can,
programs?
oh, no problem. I can safely say that we had money allocated, and for those services that we needed to be sustained are sustained, and all the money that's allocated for ARPA funds are slated to be used. So we're in good shape there.
Right. And I'll just editorialize at the very end. I have much love and respect for our co-chair, but I do differ slightly. And the community that I represent, mobile care crisis has been a vital resource, and I will.
Children?
Yes. So we'll chat offline. Thank you. But I do want to just make that point, and we'll chat. Thank you.
All set, Senator?
Yeah.
Representative Gilchrist.
Thank you, Madam Chair. Good to see you.
Good to see.
Thank you for being here. Was just hoping that for the work group, you could bring a chart that illustrates kind of, because your agency's gotten a fair amount of ARPA, just an understanding of where ARPA dollars have been used, where this budget fills in for those ARPA dollars and where it doesn't, just so we can know.
Absolutely.
Okay, that'd be great. Thank you. Also to piggyback off of Rep Walker with the overtime and the salaries, I'd really love to know what these salaries look like for the social workers. But also, since you said the overtime is high in the hospitals, kind of what are those job classifications and what's that look like too?
Absolutely.
Thank you.
Mhm.
And then if you could just talk us through So I see here, there's suspend private residential treatment center care rate increases, but then I do see the amount of money on the next page in the provide funding for private residential treatment facility rate increases. Can you just speak through what is that move? What does that mean?
So that represents a cohort of providers that are paid per diem at a rate calculated through the single cost accounting. They are usually excluded from COLAs, but in DCF practice, they are always included in our COLA. So that way we're not double funding them in terms, because we always include that cohort in our COLA allocations. So that's why you sort of see it in one place and then it's taken out in the other.
Okay. And is that ongoing that'll be moved? I mean,
Well, it's by statute. That rate increase is required by statute. But again, in practice, we always include them in the COLA. So we're complying with the statute, but we also include them in the COLA. So just to make sure that they're not getting a double benefit.
okay. And then are they the same providers or is it different in looking at board and care for children, short-term and residential? Who does that capture? That line item?
I don't have that detail with me right now. If it's possible to bring that to with the work group, I'd be happy to.
That'd be great, because my final question, with regards to that line item, I see that you all recommended an increase from your fiscal year 25 allocation. And then the governor's recommended actually reduced what you have. So just wondering what those services are, what you intended to use that increase for, just so we can get a better sense of now where we're kind of left at. Thank you.
Absolutely.
Thank you, Madam Chair.
Representative Nolan.
Thank you, Madam Chair. Good afternoon. Just want to go back to the funding for the juvenile review boards. That's a little scary for me with the shift in funding. And I just want to make sure, because in order to make sure that a program works very well, you need the funding when the program's supposed to start. So my worry is that by not having that already, that by the time you're ready to start it and you get everything that's supposed to be done with post, it will be delayed. So are there any things that we need to prepare for that, you know, that you're gonna need that funding for, or you have funding for already? Can you break that down for us?
Sure. I would be more than happy to give you a detailed report of all the happenings of the JRBs at the working group. But what I can tell you is that there are JRBs already operational, right? And what we found is that there were gaps in JRBs. And so we were going to, as a department, fill in those gaps. And so, but we wanted to make sure that we did a comprehensive review as to how to fund them, where to, where to stand them up. And so it's a delayed implementation of just those JRBs. And we don't believe that there will be a further delay beyond what we've already experienced. So.
Okay.
So we can give you more information about the details of the rollout, but I don't see it as a delayed sort of, I don't see it as a gap at this point. It's just a delayed implementation, if that makes sense.
Okay. And I have to come back. I just lost my other question. Thank you.
Representative Exum.
Thank you, Madam Chair. Good afternoon. Good to see you, Commissioner. I just wanted to, when speaking about the emergency mobile psychiatric services, this is the program that's typically offered through 211, correct? So I think it would be wonderful to have an opportunity to tell a little bit about this program, because I also know the value of it. So if you could give us a little more information about it. I see the funding there, but I think it's important to contextualize the program.
You want it now or for the working group?
If you
Now?
you could do a little bit now, and then for the working group, I think it would be important to do.
Oh, yeah, I'm happy to do that. I'll have Frank sort of come up and join me. But I'll start by saying it is an invaluable service. When you're in the midst of a crisis with your child, to have someone come to you is very different than having to kind of go out. And so we've seen incredible value in terms of use and in terms of convenience and in the middle of a traumatic episode, just to have a variety of ways that families can have access to mental health service is, I believe, the key in making sure that we're meeting families where they are.
And this allows for the 24/7 delivery of service, because at one point that was different.
Absolutely. Things like the urgent crisis centers that are 24 hours that families can go and access. We're very proud of that, by the way, that of standing that up as a 23-hour service. And it's not like the emergency rooms, which can be a little tough for families. It's more conducive to de-escalating some of the behaviors that we have with our children. So I believe that's what makes Connecticut unique, is that we have a variety of ways to respond to the community.
Okay, thank you very much. And I have a question about the grants for psychiatric services for children. What is that when it goes under, there's a line item, grants for psychiatric clinics, I'm sorry, for children. What does that look like?
Hi, Frank Gregory, DCF Behavioral Health Community Services. We, as DCF, license outpatient clinics for children. By statute, there are a certain proportion of those where the department is charged with identifying essentially what used to be called the child guidance clinics, and there's funding attached to those contracts. So there are a number of licensed outpatient psychiatric clinics for children that receive some grant funding toward their infrastructure costs. And so I believe that's the line item there.
Oh, I see, for infrastructure. Okay. All right, thank you. And then as you mentioned, the UCCs, and I know the funding is DSS, but as far as individuals who aren't on Medicaid, how does that look as with commercial or private insurance? What if we could get some information on that as well? Certainly welcome to bring it later, but that's something I'd be really interested in knowing what that looks like and what the utilization looks like there.
Absolutely.
Thank you. And finally, if we could also see, where would I find the information for the ICAPS program and for those grants as well, potentially to families who are private or non-Medicaid, if I could get information on that as well. Okay. Thank you.
You want to say answer?
Do you have that today?
We can answer. Yeah.
Hi, the ICAPS programs are funded almost exclusively by fee-for-service reimbursement. We did facilitate some additional grants with the ARPA money this past term, but those were one-time funds. So beyond those, we don't have existing contracts with ICAPS providers to fund the provision of those services. We do have a contract that funds some of the QA and training, but as far as the service delivery, that is all fee-for-service reimbursement.
Funded through Medicaid. Yeah.
Through that. Okay. Thank you. Thank you so much. Thank you, Madam Chair. Thank you.
Representative Dathan, followed by Representative Nolan.
Thank you so much. And thank you, Commissioner Hillary. It's nice to see you here today with your team. I am in the Government Oversight Committee, and one of the things we do is we look at audit reports. And I notice you all haven't been audited since 2018. Hopefully your new CFO can help with that process when we start that. But one of the comments there, and a number of the comments kind of alluded to, we have a lot of overtime that's not authorized. We're not doing the reports. And I guess one of my concerns when you're talking about eliminating about 100 some odd positions and reducing your total personnel services by 18 million, And you indicated that you have a workforce that is really worked really hard and it is a tough job. If we want people to stay in these jobs, because the continuum of services is so important for these children, and to have that, I have some concerns about eliminating positions. So my first question really is, have you all been able to address some of the items that were brought up in your 2018 audit report with your current staffing levels?
Well, I think for the agency, we're always trying to address efficiencies around overtime. I think what frustrates the issue was certainly it feels like we're always being audited. I think what happens is that they haven't all been published yet. So some of that, you'll see certainly some progression, but immediately we're still beyond the COVID year. So we're also having to staff these 24/7 facilities in a very challenging time. So immediately you're going to not see probably the progress that we're trying to make. But we're certainly trying to get under the overtime issue. It's certainly frustrated with vacancies, but we're comfortable with the governor's budget as has been promulgated.
Okay.
And I just want to make sure that you hear that we're audited all the time.
Well, I saw your kinship, I saw your performance audit on kinship, but the financial audit, it hasn't been done since 2018. So that's definitely pre-COVID. So my second question, really, you kind of started in there. I think you read my mind, was really understanding how many children are served within your supportive housing, board and care for children, and all your different programs. So if you can bring to the working group a census of those and like a trend, so we kind of understand how that's working. Again, I have some concerns that, you all are looking for increased financial support in each of those areas, but just wanted to see how those are looking. So thank you so much, and thank you, Madam Chair.
Representative Nolan.
Thank you, Madam Chair. Going back to the mobile crisis, do you have data that can show how much that it's being used and some of the outcomes from it? Obviously there's for a while been a lot of pros and cons in regards to that. So I think that would be interesting to see some of the outcomes from that when it comes to the data.
Absolutely. We'll bring that to
Other
them.
question, the UCCs, are those funded through DSS or DCF? Are they going to be coming to DCF, the funding mechanisms, the control, I guess, of the funds?
Thank you for the question. They were initially funded through ARPA funding. And now we have worked out a bridge with DSS, and they are now Medicaid funded. Thank you.
Could you share what the what amounts of money are going to be used to go out to the UCCs and how it's divided up?
Sure.
Thank you.
I can do that. Absolutely. Thank you.
Are there any other comments or questions? Seeing none, Commissioner. See, we didn't treat you badly.
Thank you. Appreciate you.
All right, we'll see you soon.
All right.
We're going
take
to
care.
adjourn the meeting for the Human Services agencies. And we will not have the public hearing tonight as the House will be in session. We will be having the public hearing for these agencies on, I believe it's Friday, from 10 a.m. to 10 p.m. 10 a.m. to 10 p.m. Very good. Do you know how many people we have yet? All right.
Oh, yay. We want to invite all you DCF staff here to come in and sit with us starting at 10. We'll provide.
10 a.m.
water.
to 10 p.m. They're usually here.
We'll provide water.